Yeah, thank you. Good evening, all. Welcome to Pediatric Endocrinology for Postgraduates 2022. Happy New Year to all. I welcome our President, Dr. Shaila Bhattacharya, who is Professor of Pediatric Endocrinology and Pediatrics from JJ Medical College, who is very enthusiastic and dynamic president of our ISPE. We have done many programs and especially to teach the pediatric endocrinology to the remotest place of India. It was planned. This is the third time we are doing. We are having very eminent faculty, two past secretaries of ISPE, immediate past secretary, Dr. Ahila Ayavu Madam. She is from GKNM Hospital, Coimbatore, who was also my teacher and very good mentor also. Dr. Anurag Bajpai sir, who was also past secretary of ISPE and he is director of medical E-classes of pediatric endocrinology. We are having Dr. Riyaz sir. He is from Trivandrum Medical College, associate professor, who is my senior and also mentor. Welcome you all. Raghupati sir will be joining very soon. He is the patron and main backbone behind this program. Now I request President Dr. Shaila Madam to initiate the process. Thank you.
Good evening, everybody. It's my privilege to speaking to you all because you all are the budding pediatricians. You know, in next few years, you all may be budding pediatric endocrinologists also. So, we from Team ISPE welcome you all for this teaching of the postgraduates, pediatric endocrinology for postgraduates. I'm very happy this time. At the starting itself, we have good number. I can see more than 45 attendees. So I'm very happy you all have joined from the early itself. And also, last minute, Lynette had to do the case presentation. Thank you, Lynette, for doing it. But I request all other postgraduates, not only listening and learning, but I think you all have to start presenting because we are doing this once in 3 months. If you are enthusiastic, we don't mind doing every month or every 2 months, but you all have to come forward because when we were students, we never had any pediatric endocrine teachers at all. You all had to go abroad or somewhere and learn what is, even the spelling of pediatric endocrinology was not known. But you all are very lucky to have so many classes going all around. So I think you all have to make use of it, but please come forward and we can make only case discussions rather than we all talking and giving lectures. That would be more interactive and which will remain in your brains for longer time if you are discussing more cases. So I welcome you all to this and I should thank Dr. Amarnath because he is the person who is really working for this. He is the one who is taking forward all these things. I think we should congratulate him for his hard work. Please continue with Dr. Amarnath. So I leave Amarnath to continue all the future proceedings. So the case presentation and 2 talks by Dr. Anurag and Dr. Ahila. And any feedback is there, please put it in the chat box so that we also can improve more. Thank you very much.
Thank you very much, madam. Already 62 participants. So we are very happy. Just I will tell how will be the program. We are having only one case of diabetic ketoacidosis. And same case will be discussed for the both presentation of DKA and ambulatory management. Means after management of DKA, how will you manage and adjust the insulin for the same case? And afterwards, first lecture will be by Dr. Anurag Bajpai sir, recent advances in management of diabetic ketoacidosis, followed by Dr. Ahila Ayavu madam. She will be speaking about the ambulatory management of diabetes. Then third part will be OSCE in pediatric diabetes by Dr. Riyaz sir. Then followed by few theory questions of diabetes like continuous glucose monitoring, time in range, and what are the newer insulins. So this time they are asking insulin analogs. So based on the DNB and MD DCH pattern, this program is aimed. First, we'll go to the CV. Ankit, shall I share the screen once? Yeah. So sorry for the delay. So Dr. Anurag Bajpai sir, he is a consultant pediatric adolescent endocrinologist in Regency Hospital, Kanpur, and also Fortis Memorial Research Institute, Gurgaon. He is Secretary Treasurer ISPE 2017 to 18, Secretary Grow Society IAP Kanpur, and Director Medi Classes Learning Grow Society. And he has done FR ACP from the Royal Australian College of Physicians, trained at Royal Children's Hospital, Melbourne. Book chapters in 36 books on pediatric endocrinology. Sir is very enthusiastic. He has written when he was doing MD pediatrics from AIMS itself, and he was the favorite student of Dr. PSN Menon. He has over 300 presentations in state, national, and international conferences. Dr. Ahila Ayavu, who was past secretary of ISPE, presently senior consultant pediatric endocrinologist, GKNM Hospital, Coimbatore, and Aditi Hospital, Trichy. And she has very many major achievements. John Funder Prize of Best PhD Research Publication 2013, and nominated for top 18 doctoral from University of Auckland, recognized guide for PhD in pediatric endocrinology and diabetes, and many publications in JCM, American journals, and Journal of Pediatrics. And Dr. Riaz sir is associate professor from the Government Medical College Trivandrum. He is secretary IAP, past for the Kerala, member Central IAP Executive Board, and co-author for guidelines of ISPE hypothyroidism. And they have established the MISTI program, that is the free insulin and the glucometer, and also insulin pump for the whole state, the pediatric diabetes children. We welcome you, sir. We want your inputs for the all pediatricians and budding pediatric endocrinologists. They should know how they can do social service about 1 to 2 minutes. So me, next is Dr. Marnath Kulkarni. I am the presently DNB academic coordinator and senior consultant pediatric endocrinologist from Lotus Hospital. Thank you. Over to you, Lynette.
Can I see your slide? Can you see the slide, sir?
Yes, we can see.
Go ahead.
Good evening, everyone. I am Dr. Lynette, third year pediatric resident from Sagar Hospital, Bangalore. Today we will discuss a case of 14-year-old boy who is hailing from Bangalore, Hindu by religion, informed his mother and himself. It has a reliable history. So he presented to our emergency department with the complaints of increased frequency of urination and thirst since last 15 days and generalized weakness since 15 days. Then he developed vomiting and abdominal pain since last 3 days and then breathing difficulty since last few hours before presenting to our hospital. This 14-year-old boy who was apparently normal till 15 days ago and presented to our hospital emergency department with the complaints of increased frequency of urination, thirst, and generalized weakness. He then developed vomiting since last 3 days, which was 5 to 6 episodes per day, non-bilious, non-projectile, and containing mainly food particles. He also had history of abdominal pain since last 3 days, which was diffuse, dull aching type with no aggravating or relieving factors and without any radiation. His parents complained that he developed breathing difficulty in the form of increased respiratory rate since few hours. There was no history of fever, loose stools, or burning micturition, or recurrent skin infections or balanitis in the past, thyroid disorders, or recurrent abdominal pain or loss of consciousness. No similar illnesses in the past or no past history of recent viral infections or mumps infection. He is a first child of non-consanguineous parents. There is no history of diabetes or autoimmune disorders in his family. He is a term born by normal vaginal delivery with birth weight of 3.5 kg. He cried immediately after birth. There is no significant perinatal history. Developmentally, he attained all age-appropriate milestones. He is studying in 9th standard with average scholastic performance. He is vaccinated according to national immunization schedule. He belongs to upper middle class socioeconomic status according to modified Kupusami classification. In emergency department, on examination, he was sick looking, dehydrated, with deep sighing respiration, with fruity smell of breath. He was conscious, oriented to time, place, and person. On his anthropometric evaluation, he had his height was 153, which comes between 10th and 25th centile according to IAP growth chart. His weight was 36.6 kg, which comes between 10th and 25th centile in growth chart. His BMI was 15.6, it comes between 10th and 25th centile. On vital examination, he had tachycardia with heart rate of 120 per minute. It was normal volume, a regular rhythm with peripheral pulses were felt, no radioradial or radiofemoral delay. He also had tachypnea with respiratory rate of 34 per minute, deep sighing respiration without any retractions. His BP was 100/80 in right upper limb supine position between 5th and 58th centile. His saturation was maintaining in room air 99%. Temperature was normal. On general examination, he was sick looking, but he was conscious and oriented. His eyes were sunken, but absent tears. Oral mucosa and lips were dry. No oral thrush. Deep and sighing respiration with ketotic smell. Skin turgor was lost. I carefully looked for other signs of infection elsewhere in the body. It was not there. His SMR staging is stage 4 according to Tanner staging. He had breathing difficulty, so I would like to start my systemic examination with the respiratory system. He had a fruity odor of breath with respiratory rate of 34. He had tachypnea without any restrictions. He had deep sighing respiration, but on auscultation, he had bilateral normal vesicular bed sounds was there without any added sounds. On abdominal examination, it was scaphoid abdomen, tenderness present over the epigastric area. There was no organomegaly formed. CNS examination, he was conscious, oriented. His GCS was 15/15. His bilateral pupil equally reacting to light. Tone power reflexes were normal. On CVS examination, he had tachycardia, peripheral pulses were good. BP was maintaining between 9th and 58th centile. His heart sounds were normal without any murmur. With this history and evaluation, we have done initial evaluation. It showed arterial blood gas analysis had pH of 7.1, partial pressure of carbon dioxide was 11.6, PO2 of 114, bicarbonate of 7.3, base of -25, lactate was 21. It was suggestive of metabolic acidosis with respiratory partial compensation. He had a GRBS of 389. Urine ketones were positive at that bedside. Serum ketones were 40. HbA1c was 13.2. His electrolyte showed sodium of 140, potassium of 4, chloride was 111. With this GRBS, his corrected sodium was 144.6 and effective osmolality was 323. On the basis of clinical examination and our initial laboratory findings, diagnosis of moderate diabetic ketoacidosis was made and airway breathing circulation was sequenced. Diabetic ketoacidosis treatment was started according to ISPAT guidelines.
Just wait here. Go back. Now I request examiners to, especially Riyad sir and Ayla madam and Anurag sir, if you want to ask any questions regarding to the history and examination. Because we are discussing the examination case. Any few questions, Riyad sir? Then we'll go into DKA part, because though we have told 2-time presentation, we are going to complete within first 10 minutes itself. So I will start with the discussion. Can you tell what is the importance of age of presentation?
Sir?
Age of presentation.
Age of presentation, if like early ages, there's a chances of more ketosis. Ketoacidosis is more common in the less than 5 years of age. And duration of illness also.
So, yes, Anurag sir.
Yeah, so I think it was very nicely presented. What will be the pointers which will suggest that there will be a risk of cerebral edema at diagnosis? Because that's something which is very important. And did you specifically look for that?
Yes, sir. His level of consciousness is main thing we can identify whether it is cerebral edema is there or not. If here this patient was completely conscious and oriented and responding well to our questions, and then next things on evaluation, we can see we have to look for a severe acidosis or like hyper urea level. If it is high, there is more chance of going into a cerebral edema.
Okay. I think the case was presented very nicely. I think there's not much issues to discuss from there.
Just one question from the pediatric side, sir, though, because it's a pediatric case. Can you tell the organomegaly with diabetes? What are the various causes of organomegaly with diabetes? So we are asking from the general pediatric side. Please, Lynette, don't confuse yourself. Where you can see even type 1 diabetes with organomegaly. What do you think? Any hematological condition which can present with diabetes?
Yes, sir. Thalassemia, sir.
Very good. Very good.
Because of repeated blood transfusion, because of iron overload, they can affect the pancreas, then they can go into diabetes.
Very, very good. Yeah. What is the importance of blood pressure with diabetes?
Like in diabetes, there is like if they are in DKA, there is a chance of like they can go into shock, sir. So if it is like BP is less, means the patient is because of dehydration, they can go into shock. But most of the time they won't present with shock because of like high osmotic pressure in the intravascular component.
Very good. Leave about this type. Any other type importance of blood pressure measurement? Obese child coming to you.
Yes, sir. Obese child with the diabetes and hypertension, we have to suspect metabolic syndrome.
Very, very good.
Can I add a point?
Yes.
So in type 1 diabetes, we use blood pressure and pulse rate to guide our therapy. If you have tachycardia and you have blood pressure which is normal, that is compensated shock, particularly if you feel the peripheral pulses in your peripheral pulses are not felt well. If you have tachycardia and your blood pressure is dropping, then you're going into a stage of uncompensated shock. It also tells you how to guide your therapy. That way, pulse rate and BP are very, very useful in guiding therapy also, not only in any other purpose. Thank you.
Thank you. Just a code word for the all pediatric postgraduates. Remember to look for CID. C means consciousness level. I means source of infection. D means dehydration. So act like CID whenever the patient of decay is coming to you. So it's very, very important. Most of the times you have treated the patient, but fungal infection is going on, resistant infection and acidosis and hyperglycemia. Riyad sir, you have any questions?
Just a comment, like actually to prevent the decay from happening, we should start suspecting decay. So like when you're taking the history, a child who is already who has attained the milestone of dry by night, then again starting bedwetting. One thing we have to consider is again it could be diabetes, it could be because of the polyuria. Only if you suspect or only if you think of diabetes, we can prevent crashing to the hospital with the decay. We have to identify such children before the child goes for a diabetic ketoacidosis. So in history, all these questions we can ask.
Thank you very much, sir. Lynette, can you go back to your growth chart, please, once? So just I wanted to share, as she is a student of Raghupati sir, I am also student of Raghupati sir. It's a question to Lynette. So a case of hypothyroidism was coming follow with Raghupati sir. He charts the growth chart height and weight every time. He started seeing some changes in the growth chart and diagnosed diabetes before it is going into ketoacidosis. Can you tell what is the clue?
Weightage, sir. Weightage and heightage, sir. If it is weightage comes less, he is having malnutrition or like he's losing his weight. So his weightage is low means it is losing his weight acutely. So then we
Very
can
good.
suspect.
Very good. What else? Suppose a diabetes child is coming. Again, next extension of that question.
Okay, sir.
Started losing the weight. What else you will suspect? Hypothyroidism you have ruled out. Anything else? What you should screen after
Celiac
diagnosis?
disease, sir.
Very good. Excellent. Celiac disease. Thank you very much. He has used the recent growth chart. So you have to use this. Can you tell about this growth chart, please? This is ASCII for you.
Yes, sir. This is our latest IAP pediatrician friendly growth chart, sir. It has it is boys growth chart for height as well as weight. It has centiles from 3rd centile to 97 centile. And it has included a mid-parental height percentile calculator along with the growth chart, sir.
Yeah, above, can you tell about the BMI chart? Is from what age?
My chart also included in that. It has like underweight, overweight, and obese category. They have given 3 lines. If the patient comes below above the red line, we can consider it as
very good. Rajesh is answering from 8 year onwards. So we thank all participants who is doing the active charting. Thank you, Rajesh. So other people also should answer. This presentation is for everyone. So 3 things added newly in this thing. First one is the mid-parental height on left side. Second one, the 3rd centile is made red color so that we will be identifying a very early short stature. Third one, BMI friendly. So you can just by using the scale, 2 scales, you can calculate the BMI. Go ahead. So you have done excellently. Can you tell what are the other causes of polyuria, polydipsia, polyphagia other than diabetes?
Diabetic insipidus can present at polyuria and polydipsia, sir. Then,
what are the other causes of only polyuria, not other things? Polyuria in pediatrics. Causes of polyuria. Others can answer. RTA, someone is telling. UTI. What else? Swati, Dr. Swati, you are the discussant. You can. Tubular dysfunction. Very good. Which electrolyte abnormality can present with polyuria? Very good. Hypokalemia and also hypercalcemia. Right. Go ahead. Thank you very much. Very good presentation. Please note, examiner can ask anywhere from the pediatrics. Don't think that pediatric endocrinology case is there. So that is the idea of this case presentation. You should be thorough in all the areas of pediatrics. Excellent presentation, Lynette. Go ahead. Thank you very much, all the examiners.
On the basis of clinical examination and initial laboratory findings, diagnosis of moderate diabetic ketoacidosis was made. Airway breathing circulation was adequate. Decay treatment was started according to ISPED guidelines. So initial 10 ml per kg normal saline bolus was given. Since it was a moderate decay, dehydration correction 7% was done done over 48 hours along with maintenance IV fluids according to Holiday Cigar formula. 40 millimoles per liter of potassium added to the maintenance IV fluids in each mile. Insulin infusion started at 0.05 unit per kg per hour, 1 hour after the beginning of the IV fluid therapy. IV fluids, normal saline and DNS and 10% DNS were interchanged according to the GRBS level. Vitals, GCS, GRBS, blood gases, urine ketones, serum electrolytes were monitored at regular intervals. Started orally as his general condition improved, and insulin infusion was stopped 30 minutes after initiating subcutaneous insulin according to basal bolus regimen as his acidosis and ketosis normalized just before a mealtime. Child and parents were counseled regarding the nature of the condition and requirement of insulin for lifelong. Parent education sessions regarding home management of insulin was carried out. Home blood glucose monitoring, administration of insulin, recognition and treatment of hypoglycemic episodes, management of sick days were taught in details to the child as well as parents. Counseling regarding meal plan and exercise has been done. Child was screened for thyroid disease at diagnosis, and child has been discharged with plan of daily insulin administration and orders for follow-up. We have sent him home with insulin of injection Novorapid 8 unit 3 times daily with Lantus 12 units at bedtime.
Now I request both the examiners, Anurag sir and Ayla madam, can ask the questions.
Okay, so did you give the long-acting insulin one day before shooting subcutaneous, or you gave it simultaneously along the same time with the short-acting as well?
Actually, we have given along with the short-acting, sir. We didn't start fairly. Actually, ideal new recommendations are recommending to give 1 day prior to the initiation of subcutaneous injections. Sir.
Sure. And how frequently were you monitoring the electrolytes?
Electrolytes every 4th hourly, sir.
Suppose you had persistent hypokalemia which was there and it was not getting corrected despite going up the potassium up to 60 millimoles per liter. What steps would you take in terms of preventing the complications and looking at the cause of hypokalemia?
In decay, usually hypokalemia is because of the shift of potassium into the cells, sir. So for preventing that, we are adding potassium into the maintenance IV fluid. If the patient has any symptoms of hypokalemia or any ECG changes, we were continuously monitoring to see any hypokalemic changes. If any changes or like severe hypokalemia, we have to treat acute correction of potassium.
Anything else which we like to reduce the treatment dose of something?
Insulin dose we can reduce, but like we have to consider ketosis also during that period.
So suppose your potassium is 2.8, what would you do? Would you continue same dose of insulin, reduce insulin, stop insulin?
We can, if the ketosis is in the coming down and he's in improving, we can reduce the insulin dose.
And any other deficiency we like to think of that can cause hypokalemia in the setting? Any other electrolyte deficiency?
Ruchi is saying magnesium, hypomagnesemia.
So I think key issue is that potassium is what? If your potassium is very low, you are more at risk of dying because of that hypokalemia urgently rather than because of that ketoacidosis. So the first priority should be to avoid the complications. So as you rightly said, increase the potassium infusion rate, give acute correction, think of magnesium. But if you are in very severe levels, maybe withholding insulin for some time is not going to be a very, it's going to actually be helpful in that urgent dire setting.
Lynette, can you tell about the priming? What is priming of insulin when you start the infusion?
Timing, sir.
Yeah.
So, ideally, we have to start after starting 1 hour of dehydration therapy. So dehydration therapy, after 1 hour, we can start insulin.
How
We
will you
should not
prepare?
start immediately, sir.
How will you prepare the insulin and start infusion?
Insulin, we can prepare 50 ml plus 50 international unit. It can prepare. It will be 1 ml is equal to 1 unit. We can start with 0.05 international unit to 0.1 international unit per kg.
After mixing, you want to give just like that? After mixing, you want to give just like that, or you want to do something? Some procedure is there.
Slow IV infusions.
Someone is saying time the line, flush the line. What are they saying? Huh?
We have to flush the line with the insulin.
Why you should do that? If you don't do, what will happen?
Adequate amount won't be delivered. Proper amount which you want.
Very good, Swati. So insulin will be attaching to the tube, negative charge, and it will not go. So there will be no improvement. This is called priming. The most important thing most of us forget. So do that and write, label that priming has been done. So at least 10 to 15 ml of after mixing insulin with the normal saline, you should flush through the tube. Right, very good. Ahila madam, do you have any questions?
I have, that's an absolutely brilliant presentation. Very, very well done. All the best. I have no questions for you.
Yes, sir. So just I have one question, quick question. This is for the pediatricians and also other pediatric residents. So whenever diabetes patient is coming to you, you need to take the history as patient went to other pediatricians or not. Before referring, initial insulin was given or not. Ragupati sir used to say, many patients from Kerala, they used to refer to the CMC Vellore. At least 10 to 20% of the children used to die in the train itself in olden days, 1985 or in 90. So what precaution you need to do whenever you are referring a child to the pediatric endocrinologist? Lynette or Swati, anyone can answer.
We should correct the dehydration and
Swati, anyone? Not to give bolus insulin, to eat bolus, dehydrate. Very good.
Whether he had received bolus or insulin there previously or not, and accordingly plan the 48-hour dehydration.
Yeah, before referring to the doctor, referral doctor, hydrate first one. Give 0.1 to 0.3 units per kg of human actrapid and record it when you are referring has been given. It can prevent the decay. It's the most important step we should know whenever you are referring a patient to the higher center. So tell about the hydration. Second, give one shot of short-acting insulin, preferably human actrapid, 0.1 to 0.3 units, not more than that. And whenever you are giving insulin, you should monitor the sugars. Right.
Very, very pleased with the answers in the chat box. Everybody has talked about hydration. So hydration, I mean, is the most important part of treatment of DKA. Insulin comes down. Rehydration is the most important one, and slow rehydration. Because I think anyway, Anurag will be talking about risk for cerebral edema.
And also they have commented no bolus insulin. That is also important.
Very good.
Excellent. You're all very intelligent. Thank you very much, Lynette. I think we can stop and you can present the last one slide so that we'll continue. Yeah. Ela madam, your discussion is completed here only, and here afterwards only our lectures will be there. Any questions you can ask here about the insulin?
They're all doing very well.
Yeah.
They are much more brilliant than us.
Yeah. Thank you, Lynette. We'll see you in between. Now I request the most eminent faculty and most renowned teacher and the research Anurag sir to start the most enthusiastically waiting for your presentation, sir. Recent advances in DK.
Thanks a lot, Dr. Amarnath, for this wonderful invite and this wonderful program. It's really impressive, and the way you are really galvanizing the postgraduates with regards to pediatric endocrinology, it's really wonderful. And I'll take right from the point that you are all discussing about how diet treatment can have a significant impact. We had this 4-year-old girl with severe DKA who was managed initially as diarrhea, so not diagnosed early, and then referred to us, came to us with very, very severe acidosis, pH of 6.8, bicarb of 4, had drowsiness and anisocoria. Now, this is a situation wherein patients might have received a lot of fluid outside, and what we have seen, and I'll discuss subsequently, that may have cerebral edema right at the time of diagnosis. And this is something which we need to be wary about, and we have to consider that right at the diagnosis, and therefore look at the altered sensorium, look at the situation, and you will identify, and this was cerebral edema right at diagnosis. So while classical Western teaching will say the cerebral edema happens at around 6 to 12 hours, usually it can happen anytime, it can happen at diagnosis. And if somebody has received an outside fluid, as we were discussing subsequently, it is something which is extremely important risk factor to assess in that perspective. So I'll be focusing largely with regards to the recent advances with regards to pathophysiology as well as treatment options of DKA, and then big mantra which is there for DKA management in 2022 is to go slow. We're not talking about aggressive management, we're talking about slow management. Slow and steady would win the race, and this would be the dictum that I'll be following throughout in that perspective. All of you can go and have a look at our website, learning.growsociety.in, where a lot of modules are available, especially the ones on hyperglycemic emergencies, as well as various courses which provide all the information in a recorded video format in that perspective. Now, when we talk about diabetic ketoacidosis, it's basically a combination of insulin deficiency and counter-regulatory hormone excess. Both are important, particularly the counter-regulatory excess. The insulin deficiency is responsible for increased amount of lipolysis, subsequent production of ketosis, and this ketosis causes acidosis, rapid breathing, which was present in this case, abdominal pain, and the fruity odor, which was very clearly mentioned in this clear-cut presentation. The deficiency of insulin and counter-regulatory excess would cause excessive amount of glucose production in the body, and this hyperglycemia will then cause osmotic diuresis, causing the loss of glucose, potassium, sodium, and water. So there is a huge deficit as far as sodium, potassium, and water is concerned, and that's the major cause of problem which happens with DKA. Based upon these observations, we can clearly know that diabetic ketoacidosis can present largely with dehydration. Anybody who is dehydrated should be oliguric. If you have dehydration with polyuria, it suggests diabetic ketoacidosis, adrenal insufficiency, tubular damage, or diabetes insipidus. Unexplained encephalopathy of any cause, sugar should be checked, as should be in this case we had tachypnea without chest sign, again very, very significant, and abdominal pain. Even if you have mild elevations of amylase and lipase, we have to consider DKA as a possibility. Now, once you think of DKA, the next big thing is to confirm. Any patient whom you're diagnosing diabetes, even if there are none of these symptoms are present, you have to exclude DKA, and DKA criteria is very simple. It is D, diabetes, K, ketosis, and A, acidosis. So diabetes is any hyperglycemia beyond 200. Ketosis, I would always prefer that all of you should have access to blood ketone meters. They are much more reliable markers as far as ketoacidosis status are concerned. So if ketone is present, and acidosis should also be there. So you need to have all three for the diagnosis of DKA to happen. If you have only ketoacidosis without hyperglycemia, it may be organic acidemia, and very rarely, not relevant for children, a possibility of a euglycemic DKA in the setting of SGLT2 inhibitors or with recurrent vomitings. If somebody has diabetes with ketosis, but there is no acidosis, it may be somebody who already has type 1 diabetes, and the sick day perspective, it may cause that situation. And if there is diabetes and acidosis, there is hyperglycemia and acidosis with no ketosis, it is stress hyperglycemia. So remember, measurement of ketone is absolutely essential as soon as you diagnose anybody with diabetes. Otherwise, they will land up with DK over the next 2 days. Do not ask them to get back confirmatory lab values. Do not ask them to get an oral glucose tolerance test. Get a ketone levels done right at that point of time to identify the disease. Now, what are the problems which happen in DKA? And as I said, there is a lot of loss of water, and that really causes dehydration. The average level of dehydration in the setting of DKA is around 7 to 10%, but the accuracy, the clinical accuracy is not very good. Because if the tongues are dry, that may be because of acidotic breathing. The turgor may not be very low because your osmolality is more. So the thing that you have to rely out will be on urine output, blood pressure, and capillary refill. These three would be very, very important, and often we tend to use the pH as a surrogate marker of level of dehydration. So be cautious, and when in doubt, go a step down in terms of hydration, because giving too much fluid may be more harmful than giving a bit less in that perspective. There is a significant deficit of sodium, around 6 to 10 millimoles per kg, and because of pseudohyponatremia, we tend to overestimate it. So whenever you are measuring the sodium levels, you have to correct it for hyperglycemia. For every 100 milligram per dl rise of blood glucose, the sodium levels will come down by 1.6. So you have to correct the sodium to get the right value. Potassium again would be falsely high. So there is a significant potassium deficit, but because of acidosis, because of insulin deficiency, the potassium is all outside. As soon as you correct the acidosis, as we were discussing, or you give insulin, this potassium will go into the cell. So for every 0.1 decrease in pH, you can assume that the potassium levels will falsely go up by 0.6. So correct both sodium and potassium to get a good information about how you should manage in that perspective. So what are the basic tests which will guide your help on that? Anion gap is a marker of how many organic acids are there in the blood. So if your anion gap is significant, it will give an indicator that there's a lot of ketones. If you can measure ketones, it's not going to be very, very important. Corrected sodium, as I discussed, very important. For every 100 milligram per dl above 100, add 1.6. So if your sodium is 125 and your blood glucose is 600, you have to add 8 to that, because for 500, every 100 you have to add 1.6 millimoles per liter in that perspective. Potassium, as I said, for every 0.1 decline in pH, you have to add 0.6, subtract 0.6, because that's the pseudo hyperkalemia which is happening. Lactate may be required if you have persistent high anion gap acidosis. Magnesium, as I said, if you have refractory hypokalemia. Phosphorus, and this is very, very important. I've seen many cases now with the most severe decay, pH less than 6.8, where the life and death was not managed because of cellular edema, but because of hypokalemia, but because of phosphorus. So if you have a very severe decay, always measure phosphorus, and if phosphorus is less than 1, you are in trouble. You have to start phosphorus, and that will save a lot of things like rhabdomyolysis and hypokalemia subsequently. If there is signs of infection, you can look at blood culture also in that perspective. Now, large amount of this, what I'm going to talk about today, would be based upon the ISPAD guidelines, along with a couple of our own studies at our center, as well as the ISPE guidelines, which I had the opportunity to write. So this is like a combined one, but largely based upon ISPAD guidelines, which all of you should go and have a look at the website freely available. Now, as was also discussed by Lynette, that severity is largely determined based upon the pH, which is a hard marker, along with bicarbonate. And very importantly, the bicarbonate cutoff may be different for younger children. So if you have a younger child, you have to be more cautious in that perspective. So you will use a higher cutoff of bicarbonate. And if there is a mild decay, bicarb is less than 15 but more than 10, outpatient management is suitable. For moderate, you have to manage in a high dependency unit. And for severe decay, you would require ICU management in that perspective. Now, very importantly, you have to worry if a child's carbon dioxide admission is less than 10. This means that there is an ongoing hyperventilation, and this may be the only marker of cerebral edema in that perspective. If your lactate is high, again, something to worry. As was discussed by Lynette as well, if there is a lot of dehydration, your urea and BUN is high, That again is a risk factor for cerebral edema. So in our study, as we'll discuss subsequently, very severe metabolic acidosis, pH less than 6.9, outside treatment, CO2 less than 10, these are the risk factor for cerebral edema right at diagnosis, and you have to be cautious in that regards. If you have anybody with severe metabolic acidosis who is younger than 5 years of age and altered sensorium, admit in the ICU immediately, and low CO2, as I discussed, is clearly a risk factor. Now, how do we treat? And before we go ahead and do precise protocols, just to rush through the basic treatment effect which will happen. So the first part of treatment is, of course, is to give fluid. And as soon as you give fluid, the volume expands and the counter-regulatory hormones go down, and that will cause a decline in glucose by around 100 to 200 milligram per dl. So you don't need to give any insulin for this decline to happen. And if you give insulin in this first hour, you will land up in trouble because your glucose will come down very rapidly. There would be osmotic shifts, which is not desirable. And that's why wait for 1 hour before starting insulin. So subsequently, once your fluid has reduced the glucose, you add insulin, and that will typically decrease the glucose by around 60 to 100 milligram per dl per hour. And there would be a time which will come where your glucose has come down, but acidosis is persisting. Now, at that point of time, you have to add dextrose to allow the resolution of ketones and acidosis in that perspective. Studies, especially done at our center and other places, clearly show that glucose becomes normal in 6 to 8 hours, ketone in 10 to 12 hours, and acidosis 14 to 18 hours. Now remember, this residual acidosis, especially if the child is fine, has a normal urine output beyond 12 hours, is largely hyperchloremic metabolic acidosis. And for that, you don't need to do much, don't need to continue infusion, and often we tend to have an earlier cutoff in that regard, which we'll discuss subsequently in that setting. Now, before you start everything, very important to stabilize the child, ensure that there is a good airway. If the child is unconscious or has had a lot of sugar containing drink over the last few hours, put an NG tube and remove that, because as soon as the gastric emptying improves after correction of decay, this will again cause hyperglycemia in that perspective. Put 2 wide bore needles. Very importantly, do not do an early intubation. As soon as you try to intubate, the CNS pressure will go up and that will cause a havoc. So often delay intubation. Do not put central line unless absolutely essential. And if you are putting a central line, give heparin. And this is very, very important, in low molecular weight heparin. Otherwise, you will land up into problems. Do not give too much fluids. Not more than 40 ml per kg in the first 4 hours, and more than 3 liter per meter square per day. So avoid excessive amount of fluid in that perspective. Now, what should be the cause of worry? If somebody presents to you with shock, and this is very nicely discussed by Lynette, that in decay, you've got a lot of volume excess, you've got a lot of these osmoles which are there, your counter-regulatory hormones are high, so there should be no hemodynamic instability. If somebody has got shock, exclude sepsis in that perspective. If there are features of altered sensorium, drowsiness, hypertension, bradycardia, anisocoria, brisk ETRs, think of cerebral edema, give mannitol and a slow correction. Of course, look for potassium changes, look for hypokalemia, and defer insulin, start potassium in the infusion. And if there is a persistent fever, think of antibiotic treatment in that perspective. Now, the first question which comes in, whether we need to give fluid bolus to everybody. Now, we would definitely recommend it if somebody has tachycardia or shock, but I have found that even if there is a mild decay and you want the child to go home, if you give them some fluid, there will definitely be improvement because their counter-regulatory hormones will come down, maybe a slower fluid will be good. So before you don't want to admit them, give them some fluid in the emergency, give them some subcutaneous insulin. They will have a much better outcome in that perspective. The dose is typically 10 ml per kg, usually over 1 hour. You can repeat if shock is present, but do not give more than 2 boluses and never give more than 40 ml per kg in the first 4 hours. This is what we discussed earlier in that perspective. Subsequent management is very easy. The SPAT guidelines talks about maintenance and deficit over 48 hours. So the typical holiday Sega formula 4-2-1 rule, along with the dehydration level 7 to 10%, you can then decide about giving it over a 48-hour period. Normal saline is a preferred drug in that perspective. but there are now studies which show that you can use half normal as well, usually less than double maintenance. And if you have a child who is above 30 kg, better to use the BSA based formula of 1.5 liter per meter square. In that perspective would be the appropriate one to avoid unnecessary too much fluid. Now, there has been a lot of discussion, especially in the Western age group, and this is an important recent advance. This was a large multicentric trial, the PECA and DKA fluid study, largely done in Western centers in milder cases of DKA. And what they said that whatever fluid you use, whether you use normal saline or N/2, you use it slowly or you use it rapidly, there is no difference with regards to the CNS outcome. The children who develop altered sensorium do not differ. So what they're trying to say is that in these individuals, fluid does not make a huge difference in that perspective. But remember, the average pH in these patients was 7.17. The one in our study from India was 7. So we are having much more severely affected individuals who come to us with DKA. It may not be appropriate to extrapolate these findings, which are there for milder category of DKA, in an already good setting to our setting. And in that perspective, I would say avoid rapid fluid, use normal saline, because if you use half normal, there will be a rapid fall. If you have somebody who is 7.17 pH, often we tend to don't even manage in the ICU definitely. In that setting, you can use any fluid. But usually if you have a severe DKA, be cautious. That's something which is very, very important from that perspective. Now, what about insulin? So fluid is a fundamental aspect to start off. Insulin ideally should be intravenous insulin, but there are definite protocols which have been shown from Dr. Raghupati and Dr. Ahila's group, the Vellore group, and who have shown that intramuscular insulin is another way of managing DKA. Again, definitely a good one in resource poor settings. So if you have somebody in a remote area, you give them the intramuscular injection of insulin, which may work for around 2 to 3 hours. Give them some fluid, stabilize them initially, and then refer. And write exactly what has been given, as Dr. Amarnath and Dr. Ahila was talking about. Insulin infusion, again, low versus high dose, 0.05 versus 0.1. In this case, we had used 0.05. Both are reasonably effective, and I'll discuss about the evidence for the same. As Dr. Amarnath said, always flush tubing so that you do not waste time. By the time insulin passes the tubing, don't make rapid changes. Make slow changes in insulin doses and do not dilute. So ideally 50 units in 50 ml, that will be the ideal one in that perspective. Do not use piggyback burette sets, because that can cause confusion in that perspective. Now, this was a randomized trial about low dose versus high dose. Now, not a very big study. What it clearly shows is that the lower dose, of course, had a slower correction, but the risk of hypokalemia was less. So in a way, as I said, the mantra in DK is to do less fluid, less insulin. This is something which is coming clearly from that perspective. So low dose insulin is a good option. Definitely if you have an infant, definitely if you have a malnourished child, start with 0.05. Otherwise, 0.05 and 0.1 are pretty similar in that perspective. Now, once you've started the treatment, which is very standard, the most important aspect is to monitor. The sensorium should definitely improve, the hydration should improve. Very importantly, urine output should be closely monitored. Acute renal failure, acute kidney insufficiency is very common in DK, and it is one of the most devastating complications which can cause a lot of problems. So as soon as your urine output is coming down, you have to be cautious in that perspective. Use corrected sodium, which should remain stable in that regards. Potassium should remain normal, and ketones, as I discussed, should improve and resolve by around 12 hours in that perspective. Now, how do we react to particular levels? If your potassium goes below 3.3, if your potassium in the beginning was less than 3.3, you right away start potassium in the hydration phase at 20 millimoles per liter. So the normal saline you're giving for the first dose, you add potassium there, do not start insulin. Subsequently, if your potassium is normal, you start 40 millimoles in fluid, and more than 6 millimoles you definitely have to avoid. So the only reasons where you don't have to add potassium is anuria, ECG changes of hyperkalemia, or potassium more than 6. The pointers, very importantly for hypokalemia, may be polyuria, as we were discussing about what causes polyuria in electrolyte abnormality, myopathy, And very importantly, you may give a rapid correction, increase the infusion to 60 millimoles per liter, very importantly, reduce insulin. And in some cases, we had to temporarily stop insulin because potassium, if it's not given properly in the beginning, it can cause havoc. Your potassium will go to 2.5, 2.4, and then you are on a fix. Potassium is what is going to cause death in this case, not other factors, and consider magnesium in refractory cases. Dextrose, if a sugar goes below 300, start 5% dextrose, below 200 at 10% dextrose, because glucose will come down rapidly. There will be more time with regards to the resolution of acidosis. Early initiation of glucose, of course, is mandatory. Now, this is important. There is no role of sodium bicarbonate treatment in DKA unless there is refractory cardiac event and there is refractory hyperkalemia. So no soda bicarbonate. If you have persistent acidosis, look at ketones. If ketones are high, your ketoacidosis is not resolved. If ketone is low, and then I said that if the child is normal, this could be a hyperchloremic metabolic acidosis. In that setting, you look at the chloride load, which is sodium minus chloride minus 32. If the chloride load is less, think of lactic acidosis. If it's high, it's hyperchloremic. So acidosis beyond 12 hours, if it is persisting, child is stable and it's mild, consider the possibility of alternate diagnosis in that perspective. And this is something which is self-resolving over time in that regards. High anion gap may be the other marker which you can consider for lactic acidosis in that setting. Now, bicarbonate, as I said, should be avoided. It causes CNS acidosis, it causes hypokalemia, it causes lactic acidosis. The treatment of acidosis is only given with bicarb if there is very, very high hyperkalemia, there's cardiac arrest, hemodynamic instability, and that too as infusion. So this is something, do less. So I talked about less fluid, less insulin, and no bicarbonate clearly in that regard. One key point of phosphorus, which we have now seen a lot of experiences, because of phosphorus deficiency, your oxygen delivery may be affected. It may also affect your sensorium. There is a risk of myopathy, and if there is muscle contraction, there could be rhabdomyolysis. So hypophosphatemia is something you have to be very bothered about. And the features are, if you have potassium, which is phosphorus less than 1, you have to be very worried. And if there is encephalopathy, myopathy, again, you have to worry. Best would be to give 50% of potassium correction as potassium phosphate, easily available. In anybody with severe DK, we use now potassium phosphate, that really helps out. However, you have to monitor calcium in that perspective. Now, the complications to look at in this regard would be cerebral edema, which usually happens with severe disease, too much fluids, soda bicarbonate treatment and osmotic shift. It has high mortality and morbidity, so give less fluid and slow correction to achieve a good outcome. Any child whose sensorium is becoming bad and glucose is normal, do not do an imaging, rush them for mannitol. And mannitol is preferred over 3% saline because there is also a cytotoxic component which is there. Hypokalemia happens with insulin therapy. You have to supplement. Acidosis, if it's persistent, you think of ketosis, infection, and hyperchloremia. Do not give soda bicarbonate. There could be risk of infection, so be very careful. Thrombosis, so if you have pain in the leg, it may be either a rhabdomyolysis or a thrombosis. Think of a low molecular weight heparin. And rhabdomyolysis, if there is sudden pain and there is hematuria which is happening, followed by oliguria in that regard. So cerebral edema, I said, is one of the major complications which we see in that perspective. It is both because of the osmotic shift. As your glucose goes up, the cells shrink. If you decrease your glucose quickly, the osmotic imbalance causes cerebral edema to happen. As soon as insulin therapy is given, the cells will swell up and cause edema. So this is clearly the osmotic theory. There is also now a concept that there is an intrinsic problem in DKA. So there is a perfusion, hypoperfusion, reperfusion, which causes damage. Risk factors are soda bicarbonate in that regard, severe disease, insulin bolus, too much fluids, and bicarbonate. Very importantly, it may happen at diagnosis, not related to osmolarity, and there is also a cytotoxic theory. So you have to be always cautious about cerebral edema in every child with DKA. Whatever the level of acidosis, treatment has been given outside, be more cautious in that perspective, and we have to be very, very careful in that regard. This was the landmark study which was done by Glaser et al. Earlier, which clearly showed that a younger age, recent onset diabetes and high urea nitrogen, as Leonard was saying, are risk factors for cellular edema, and CO2 again is important. In this, we have to be cautious. In our study, we found all these parameters along with prior fluid therapy, which is important. In our publication of 107 patients with DK, we found cellular edema at diagnosis very important, was very common, and after that the risk was much less and there was a good outcome. So new onset patients in prior treatment were clear-cut risk factors with odds ratio of 3.5 and 4.7. So if somebody is coming for the first time with DKA and they have received treatment outside, be very cautious. If the pH is less than 6.9, CO2 is less than 10, again, very cautious in this perspective. Acute kidney injury is something again which we are seeing a lot. It's common, and if somebody is more dehydrated and more severe DK, it becomes more common. The pointers are that if the urine output is below 1 ml per kg per hour or there are fluid overload, you have to think of it. Management of renal failure with DK becomes a challenge. You're giving too much fluid on one hand and your kidneys are shutting down. So if you don't reduce fluid, you will have cellular edema. You will have pulmonary edema. So in this perspective, what you need to do is to restrict fluid and consider early dialysis. So my dictum is always monitor urine output. If urine output is going below 1 ml per kg per hour, correct dehydration if it's present. If not, rush towards dialysis. That's the only thing which can save. Otherwise, there could be huge problems in that regards. Rhabdomyolysis is something which can happen with severe hypophosphatemia. If the levels are less than 1, usually you will have sudden onset pain in the legs, weakness and dark urine, and high CPK will give you a picture. Anybody with severe DK, monitor phosphorus. Phosphorus less than 1, give phosphorus. And if you have pain in the leg, look at CPK. The management is usually dialysis and decreased potassium supplementation in that regard. So just to summarize the overall developments with regards to DKA management, the first phase is of course hydration. Do not give too much fluid, only if required bolus will be of help. Give deficit and maintenance over 48 hours evenly. Insulin at 0.05 to 0.1 unit per kg per hour. Potassium unless there is anuria or hyperkalemia. And the third phase, as soon as the glucose becomes less than 300, you start dextrose in that regards. No role of soda bicarbonate and beware of cellular edema. So if we now talk about the DKA management as I discussed earlier in 2022, there is a tight rope. You have to balance between doing too much and too little. You can give too little fluid and that will cause prolonged dehydration. You can give too much fluid and that will cause cellular edema. You can give too little insulin and therefore you will need more time for the resolution of DKA. If you give too much insulin, there would be severe hypokalemia. Now the question is whether you will prefer a child to stay a few hours more in the ICU, correcting dehydration over some more time and maybe staying there and then going off home, or you would like somebody to have cellular edema or severe hypokalemia, the leading to causes of death in DKA. The choice is clear. The mantra for DKA management in 2022 is do less. Less fluid, less insulin, no bicarbonate, and more potassium. I think that's the key in that perspective. In that regards, what we have seen that despite all these protocols being available, there are a lot of errors which happen in management. In fact, in our center where we have a written protocol, if we carefully looked at our log, and this is just being published in Indian Pediatrics, in the Journal of Pediatrics, what we found that a lot of 80% had got a lot of errors in terms of management of DKA, and these errors could have been responsible for preventable 32%. So 1/3 of hypoglycemia, 2/3 of hypokalemia, and 1/3 of dehydration was because of these initial management errors. Now, if you do the management errors right at the beginning, you will have a lot of problems and they will not improve. And for that, we have now developed and validated a mobile application which helps you in an approach pathway along with the exact output with regards to the dose of insulin required, the amount of fluid required, how do you monitor in that perspective, and also on follow-up, which test to do and how to follow up. So this mobile application is available on the both Android and iOS store. You can have a look at it and it really helps you guide. This is one part of it to easily and use the proper protocol for appropriate management. So I think I'll stop at that point of time. It was an interesting discussion, and we'll carry forward from there. Thanks, Dr. Amarnath, for this opportunity.
Thank you very much, sir. Just one or two questions from the audience. So one question from my side is, in severe cerebral edema with severe DKA, how much fluids you want to give?
So if you have established cerebral edema which is already there, we generally want to restrict it to around 2/3 of the fluid that you plan to give. One option would be to correct it over 72 hours. The key for management would be the acute management of cerebral edema, because that's the most important. So head end elevation, mannitol, these things are very, very important. I've seen patients who are actually having just coning, anisocoria, who are having imminent coning. As soon as you do these basic steps, they improve. And then it's more like giving lesser amount of fluid over follow-up. If you want to prevent cerebral edema, I think that's what is more important in that perspective. If you have somebody who's having very, very severe acidosis, pH less than 6.9, somebody whose CO2 is less than 10, somebody who has received fluid outside, I would say right away, give a correction over 72 hours. And this is a strategy which we've been using, and it's been quite effective in that perspective for preventing of these complications.
Yeah, and below 5 years of age, we are using only 0.05 units per kg per hour.
Yeah, so 0.05 and 0.1 both have equivalent effect. As I said, ideally, if you ask me, I would say 0.05 could be the standard dose, and we may actually use lower doses in the other perspective, because often I tend to decrease the dose because we don't want that rapid fall in glucose. What's the advantage in giving too much insulin? It's not going to anyway correct acidosis that quickly. So you will have more problems of hypokalemia. That's a big problem which happens, and of course cerebral edema, which can happen in that regard.
Yeah.
So and younger children definitely do this.
Last one question asked by the audience, sir, about the use of bicarbonate. I don't think now we are using it all. So
if you have severe hyperkalemia, if you have cardiac arrest because of hyperkalemia, that is the only indication we'll be using. But that I have not encountered. I have not used bicarbonate. I've used it in one case. Now I don't want to generalize that. That was a case who had received, he was a 5-year-old child with the most severe decay, 0 bicarb. And he had been given metformin by someone, and that's why it caused lactic acidosis as well. Now this fellow, despite everything, his bicarb was not improving, his acidosis did not, his bicarb was not becoming even detectable after 12 to 48 hours, and then we had to do dialysis, we had to give bicarb. So it is for a very, there's nothing, never know in medicine, but I would say from a generic perspective, from a postgraduate perspective, this no would be quote unquote the one statement.
A big applause to Anurag sir. Every year we are listening to sir again and again. They are doing a lot of research and bringing with very good colors. Thank you very much, sir. Please continue to educate us, and please come to these classes whenever needed. We need your blessing, sir. Thank you very much, sir.
Thank you. Thank you, Dr. Manna.
Yeah. Now I request my mentor and teacher, Dr. Ahila Ayavu madam, to continue with the ambulatory management of diabetes children.
Thank you very much. Can you hear me, Amarnath?
Yes, madam.
That was a brilliant lecture by Anurag, and I think all the audience would have found it extremely useful. And they were very, there were a lot of points which will help you in your clinical practice, not only in your exams. Thank you so much, Amarnath, for this kind opportunity, and I'm thankful to Raghupati sir. And thanks to Dr. Shaila and Ganesh also for helping with this program and seeing that this becomes more useful for postgraduates. I'll just continue on from where Anurag left. So I think that was an excellent presentation by Dr. Anurag, and the presentation by our Dr. Lynette earlier also was really good, and I think they set the setting for a good presentation. So I have a written permission for the use of photographs, which I've used in this presentation, and I don't have any conflict of interest for this presentation. So I think we had enough of a discussion on when you would suspect, and all the questions have already been answered. The only point I would raise is like how Riaz talked about. When you check blood sugars, and if it's more than 200 milligram per DL, please admit the child into the hospital. There's no way you're going to ever send the patient home and ask them to come for review. I think that's one important point all pediatric trainees and pediatricians have to carry. That is how you are going to prevent diabetic ketoacidosis, so that you get the patients early and carry them forward. So I think The important point is, just a minute, 1 minute. 1 minute. Manima, நீங்களே பணம் தம்பிட்டு வாங்கிக்கோங்க. Can you hear me? Just a minute.
Yes. Yes.
Okay. So there is, just a minute. Yeah, so if you check blood sugars and you find it more than 200 milligram per DL, you have to admit the patient into the hospital for education and to prevent diabetic ketoacidosis. Any number of times you're seeing patients being asked to come back for oral glucose tolerance test to diagnose diabetes, and I think that's unacceptable. You're going to miss the golden time that you could have achieved or taught a child and prevented the child from landing in DKA. So when would you transition to regular dosing of insulin in DKA? Earlier, I think during the discussion itself, Amarnath and Dr. Anurag had this discussion on when you would add the long-acting insulin or basal insulin, whether it would be a day ahead of stopping IV insulin infusion or prior to the stoppage. Because I'm actually using subcutaneous insulin in the treatment of diabetic ketoacidosis, we don't have this difficulty in transitioning, but whenever we've used IV insulin infusion, when you have to start rapid insulin, one of the analogs, you have to give your first subcutaneous dose 15 to 30 minutes before switching off your infusion. And for your regular insulin, it has to be an hour or two before switching off infusion. You have to remember the insulin in infusion always works only for 2 to 3 minutes. So you have to remember, as soon as you switch off your insulin infusion, you're going to have no insulin in circulation. So it's important to give the doses prior to switching off so that you have an adequate level of insulin acting on the child before you switch off. And best time to transition when oral feeds are tolerated or just before a meal, it is so much easier to transition to the subcutaneous insulin. How do we do the insulin, subcutaneous insulin infusion, dosing? So we roughly calculate about 0.7 to 1 unit per kilogram per day. Please remember, in peripubertal children, they are insulin resistant. And because of DKA, the resistance may be even more. So the dosage may be a little bit higher in peripubertal children. In younger children, we calculate roughly about 0.7 unit per kilogram per day and divide it into 4 thali doses and then give it every 4 hours. And then at the appropriate time, we also start the long-acting or basal insulin and then shift to a regular dosing. We are on a basal bolus regimen, so we give a basal, and usually I prefer our glargine basal in the night, and for our boluses for breakfast, lunch, and dinner, depending on what you're going to use for your dosing. So there are several types of insulin, which I think we've already discussed about, or I think at least there has been a mention. Analogs, it could be aspart, lispro, glulisine, regular insulin, NPH, and your peakless insulins, including glargine, levemir, and degludec. I think this was a very interesting slide. There is research going on in the US currently on inhaled insulin. The earlier inhaled insulin, which was introduced in 2006, was withdrawn because of a suspected risk for malignancy because of the huge doses that were used during inhalation. But the recent advances, I think this may be out within the next few years, that would almost mimic your insulin production in a normal person. Rapid acting insulin, the insulin aspart, lispro, or glulisine, we always give it about 5 to 15 minutes before taking your meal. And the faster acting aspart, it can be given and the food can be taken immediately. We also use regular insulin in younger children because they eat more frequently and we find it easier to dose these children because they can have one major meal and one minor meal for every dose of regular insulin. We also use NPH because when you use NPH and regular insulin, you can give it as a split mix regime. The cost of therapy is extremely low. 40 unit per ml vial of NPH costs about 130 rupees. Whereas if you buy a pen cartridge, which costs 100 units per ml, the cartridge would cost about anywhere from 370 to 600 rupees, depending on what you are buying. So in certain situations, we continue to use regular and intermediate insulin as a split mix regime, but pre-mixed insulin are an absolute no-no for children. Long-acting insulin, we use glargine, and I've used glargine even in very young children, as young as 2 years and 3 years of age. I use D-gludac in slightly older children, but because the most important point that actually restricts my use is the cost of D-gludac and the amount of insulin that's available and the amount you would have to waste if you're going to use it in very young children. So those are the only two restrictive points. Otherwise, D-gludac is also an extremely good choice. I'm not a big, I haven't used 2-GO, which is a highly concentrated glargine as a basal insulin, because it's still not recommended in young children. So what are the short-acting insulins? So from the normal pancreas, this is what you would see. And when you give inhaled insulin, it might work like this. This is what they think would happen. This is regular human insulin. It works, it peaks at about 1.5 hours and lasts for about 6 to 8 hours. This is glulicine aspart or lispro, which starts working, and the first 1 hour, it works for 30% will be used in the first 1 hour, another 30% in the second hour, another 30% in the third hour, and the last 1 hour, you'll only have 10% left. And most of the carb meals will have a blood glucose, which is present for about 3 hours. So these rapid acting insulins are a good choice to cover carb meals. If you're not going to take any carbs in between, it is really good to take that. So the ultra fast acting insulin is the faster acting aspart. The onset of action is even faster than the analogs. And it is good to cover the peak, because in well-refined carbohydrates, the peak may be quite high, and these ultra fast acting insulin are supposed to cover the peak quite well. So I think all of us know basal bolus regimen, split mix regimen, which is the older way of treating patients. We still continue to use it because the cost of therapy is extremely low, and it is twice daily in some, and sometimes only thrice daily. Insulin pump is an absolutely brilliant innovation and very helpful, but the cost of therapy is the main reason for the restricted use of pumps in India. Pre-mixed insulins, not recommended in children. Whether you use 70-30 or 50-50, this is absolutely a no-no for children with diabetes. I'm just building up my presentation so that we're going to see some cases and we'll work upon how we're going to do. So these are the calorific requirements which is recommended by the United Nations. These are quite complicated to calculate. So we have a easier way of looking at calorie requirement. For boys, it's 1,180 and girls 1,140 by the Food and Agriculture Organization of United Nations. But if you look at PARC, at 1 year of age, the amount of calories that is required for a child is 1,000. You just use that. That's quite an easy way to remember. So at 1 year of age, you need 1,000 kilocalories. Add 100 kilocalories to that 1,000 for each extra year of age. So if you're 2 years of age, 1,000 plus another 100. If you're 5 years of age, 1,000 plus 400. So for each age, so it becomes 1,000 kilocalories at 1 year of age, 1,100 at 2, 1,200 at 3, and 1,300 at 4. So it is just you add 100 kilocalories for every year after 1 year, and that is the amount of kilocalories you require every day. What is the proportion of major nutrients and insulin requirement? Your fat is about 25 to 35%, and your saturated fat should be less than 10%. Proteins is about 15 to 20%, and your carbs are about 45 to 60%. So you roughly keep your carb is the only insulin is calculated based on the carbohydrate content of food. So your food will have 50% carbs. Though South Indian food actually has huge amount of carbs and very little of protein, we still need to remember it is important to have a sensible portion for all major nutrients. So it's about 50% carbs. So it's a 7-year-old child. The total calorific requirement for 1 day will be 1,600 calories. And out of that, 50% will be carbohydrate. So that's about 800 calories will be carbohydrate. Split it across meals. So for each gram of carb, you will each gram of carb will give 4 calories. So you need 800 calories for a 7-year-old child from carbohydrate. So 1600 is the total calories. Half of it is carbohydrate, 800 calories. And each gram of carb will give 4 calories. So divide by 4, you will need 200 grams of carbohydrate per day. So now all of us are educated in nutrition extensively during our pediatric training. So you know the carb content of most of the foods that you're going to eat. So you will know carbohydrate counting is essential. In basal bolus regimen, you will have a peakless insulin and you will have short-acting analogs covering the meals. Okay, so if you have a basal bolus regimen and I'm using regular insulin because it's cheaper. So I will give regular insulin for breakfast, I'll give regular insulin for lunch, and I'll give regular insulin for dinner. So what do I do? Because it works for 6 to 8 hours, we give our morning dose at usually 7 a.m. So that will work for about 12:30 to 1 o'clock. So your peak will be about an hour later. So we always give our regular insulin about 15 to 30 minutes before our meal. So give regular insulin and then half an hour later we give our meal. So you have one again, but at about 3 hours, the carbohydrate would be over, but your regular insulin will still be acting for 6 to 8 hours. So you can have a dip in the mid-morning. That's about 10 a.m. or so. If you're given your breakfast dose at 7, you can have a dip at around 10. So we always give a minor meal there with minimal carbs. Again, for lunch, we give at 12:30 and our lunch is at 1. And then we give a mid-afternoon snack at around 3:30. We always give our dinner a bit early for most children for 2 or 3 reasons. One, when they come back from school, they're very hungry. They want a huge meal. So we give our dinner by about 6:30. We give our evening dose and give our dinner a half an hour later. And we give a late night snack at about 9 o'clock or 9:30. That would have lesser carbs. So we have 6 meals, and this is something which we prefer in younger children who like to eat more frequently. For older children, we prefer analogs and we give only 3 major meals. So depending on the number of meals, we'll calculate our carbs. So we have 3 major meals: breakfast, lunch, dinner. And then we have a mid-morning snack, a mid-afternoon snack, and a late-night snack. So 2 portions of carbs for breakfast, 2 portions for lunch, 2 portions for dinner. 1 portion for mid-morning snack, 1 portion for mid-afternoon snack, and 1 portion for late-night snack. So that's 6, 7, 8, and 9. So 9 portions of carbs you need. So for the 7-year-old child, you needed 1600 calories. 800 calories is from carbs. And for that, you need about 200 grams of carbohydrate. So this 200 is divided by 9. So that's 22.2 grams of carb is 1 portion. So breakfast, they get 45 grams of carb. For lunch, they get 45 grams of carb. And for dinner, they get 45 grams of carb. For each of the snack, they get 22.2 grams of carbs. So that's how you split your carb and you also cover your insulins. If you're going to give only 3 major meals, divide the 200 grams of carbohydrate that you need by 3. And give for each meal, it will be about 66.6 grams of carbohydrate for breakfast, lunch, and dinner. And then you can style your insulin, an analog to that 3 meals. This is what we use regularly in quite a few of our younger patients. Basal bolus regime with glargine and regular insulin. So regular at 7 a.m., 12:30 p.m., 6:30 p.m. Our breakfast is half an hour later, lunch is at 1 and dinner at 7. And we always tell them what are the carbohydrates that they can give their families. We also include milk, banana, or most of the high carb fruits, everything, all roots, tubers, everything is included in this. We tell them these are the things that can be had for the major meals. For the minor meals, we use lesser carbs. We use a lot of vegetables. And then we also tell them to have green gram, sprouted green grams, and soya, paneer. And you remember all your proteins don't need much of carbs. So they can take they can take some fish, they can take some omelette or something like that, and a smaller quantity of carbs with this. This is how we do our snacking for them. So this is, I drew my own because I didn't have to buy for copyright. So this is how I give my carb. So this is our basal insulin, which is given at around 9 p.m. if you are using glargine.
Why do we give at 9 p.m.? It works for 18 to 24 hours. So if you give at 9 p.m., by around 6 p.m., the action of glargine will start dipping. We will give our regular insulin at 6 p.m. So that will take care of the dip in action of glargine and cover it, and you don't have a high blood sugar. Whereas if you give glargine in the morning, they usually have an early morning high because the duration of action is about 18 to 24 hours. It starts dipping by 18 hours. So at around 3 or 4 a.m., they start having a high. So it's quite difficult to manage that high when you give glargine in the morning. And that's why we prefer a glargine in the evening. But if you use D-Gludec, which works for about 35 to 36 hours, we use it in the morning because it helps us to achieve equilibrium and try to adjust the dosing. So this is how we give. One regular insulin for breakfast, one dose for the lunch, and one for the dinner. So if you are using with rapid acting analog, when you're using an aspart or a fast acting aspart or a Lispro or a Gluresid, we give D-Gludec in the morning because this has a duration of action for 35 to 36 hours. Glargine means it's in the evening. Breakfast, we always tell all families to have breakfast by 7 to 7:30 because you should remember your circadian rhythm. You listen to Dr. Anurag's lecture on counter-regulatory hormones. So your cortisol, your growth hormone, all of them would start raising your blood sugar even without a meal if you delay your breakfast. So that's why we always tell, even for people who are on basal bolus regimen, unless you are on a pump, it's better to have an early breakfast. Lunch and dinner can be your choice. If you want an extra carb meal or a special treat, you can take another dose of the short acting or the rapid acting analogs. Lunch and dinners as per choice, and every carb meal should be covered by analog. Amarnath, if you think I'm overshooting my time, just let me know. I'll stop immediately. So this is how
2-3 minutes.
Yeah. Okay. So this is how we cover our basal bolus regimen with analogs. So you have a basal at the bottom. It could be glargine or detimir or D-Gludec. For breakfast, one of the analogs, for lunch, and then dinner. And they exactly cover what is taken in the meal. This is the split mix regime where we combine an NPH which peaks at around 4 hours and works for about 14 to 16 hours. And then the regular insulin which works for 6 to 8 hours. So we combine both of them and take it in the same syringe. 40 units per ml, the cost is extremely low. The family can afford it easily. And that's why we prefer this in very poor families so that we don't strain the resources. If you strain the resources, they will stop treatment. So what do? We combine both and we tell families, if you take regular insulin first, it is always regular first. And you cannot push the air back or push the fluid back because you will be mixing the insulin. These are simple things that you have to remember. Because even the insulin in the needle and the hub would matter and act on altering the blood sugar. So remember, if you're taking a regular first, it's always regular. So regular and NPH in the break, just before breakfast. And then we give a 5:30 dinner because again, we finish our action of regular insulin by about 12 midnight. So they don't have a low in the middle of the night. This regular and NPH, this peak will be over by 10 o'clock, 11 o'clock. So you don't have a low in the middle of the night. That's why the evening dose is given at 5:30. So insulin is given 30 minutes before food at 7 a.m. and 5 p.m. Breakfast at 7:30 a.m. You give a mid-morning snack. You can have a bit of carbs here. The lunch will be lesser carbs, but we don't have a mid-afternoon snack. So when they come back from school, they can have dinner and a night snack at 8:30 p.m. So conventional insulin dosing, you start 2/3 NPH. So 2/3, 1/3 rule. 2/3 NPH and 1/3 short-acting regular insulin. Before 2/3, 1/3. 2/3 in the morning because of your insulin resistance due to counter-regulatory hormones in the morning. So 2/3 in the morning and 1/3 in the evening. This is only for starting. After that, your guide to therapy will be based on blood sugars. Fasting sugars, you should always tell them what the targets are. 80 to 120 for fasting and 100 to 160 or 120 to 160 for post-meal. We try to give a little bit leeway for younger children and we even accept it up to 180 and sometimes even 200 in the middle of the night. So this is how a split mix regime is there. But you can remember, you can have a basal bolus regimen even in split mix regime. You give NPH and regular here, NPH and regular here, but you also give a regular alone for lunch. because if they want to have a good carb meal, you can give, but then you will have to give an afternoon snack. I'm not sure if you want me to continue here. I'll probably finish with this point. Insulin carb ratio. So if you have this 500 is a fixed number, you calculate the total daily dose to achieve a reasonable amount of control. So if you're giving 50 units per day, divide 500 by 50. So that is 10 grams is your insulin carb ratio. So 1 unit of insulin will cover 10 grams of carbs. What is insulin sensitivity index? So if your daily dose is 50 units, 1800 is a fixed number by 50. So that is 36. So 1 unit of insulin will reduce pre-meal sugar by 36 milligram per cent. So this will help you also calculate the correcting doses for high blood sugars, and it's very useful in pump therapy also. I think I'll stop with there. If you want, I can do it later, some other time or something like that. So should not be frozen is the most important point. Never more than 30 degrees centigrade. Direct exposure to sunlight will reduce efficacy. Needle should be removed before storage because it can leak. Unused cartilages and vials should be refrigerated without freezing. We also talk about only 30 days, we ask them to change cartridges. But then if some families can't afford, for D-glutex, sometimes we say up to 60 days, for glargine about up to 40-45 days. And regular, whenever your blood sugars are going high, then we realize that it's not working and we change the cartridge. I think I'll stop with there. If you want me to continue, I'll do, otherwise I'll stop.
Just any photos you show, madam.
Okay, so this is one of my patients who was kind enough to allow me to draw on her abdomen. So this is the subcostal margin. So I prefer abdomen in most children. So we do one shot here and one pen gap is the second dose, another dose and another dose. So that's Sunday and one pen gap, Monday, Tuesday, Wednesday, Thursday, Friday and Saturday. So this is 1 week. The other side of the abdomen is second week. So this is how the distance between the doses is kept. And please remember, we always hold, we always pinch. It's important to pinch in children and do it at 45 degrees. 90 degrees is for older people and heavier people. For children, the recommendation is 45 degree. Pen needle 4 mm is good enough. It's painless and it's very good. So this is how we do. And then we do the gluteal region too. For glargine, I prefer the gluteal region because the pH is 4. There is a stinging sensation and children don't like it. So for glargine, I prefer the gluteal region, but this is 1, 2, 3, and 4. And thigh is another area which we use in a bit older children. We don't use arms, I think, almost ever in children. If you inject in the same site again and again, you will have lipohypertrophy, and people will think this boy was exercising to lose his tummy, but he actually had lipohypertrophy. Washing and drying of hands prior to insulin handling. Wash with soap and water. We don't use spirit as much as possible. Sometimes you may need, we count to 5 for syringes, 1, 2, 3, 4, and 5. For the pens, it's up to 20 counts so that all the insulin is delivered. Yeah, I think I'll leave it at.
Thank you very much, madam. Giving injection is also an OSCE station. So you have covered to the maximum. Just last one question from my side. Before sending the patient to the school, what instructions you want?
What?
Sending the patient to the school, child. Instructions, what you want to give?
Okay, so we actually, because most of them are on basal bolus regimen. If the mother can travel, we tell them to take the insulins and go. Otherwise, the child will carry it we just ask them to wrap it in a dark towel and keep it in the staff cupboard, which is not very hot or near the sun. And they also carry an emergency kit bag, which is kept with the teacher. They have a glucometer in that, a few strips, a bottle of juice, and then if they have glucagon, they take glucagon if the teacher knows. Otherwise, we just give them some glucose powder in a sachet, and then some snacks also. If they have a low, they check, and they also have an emergency number in that box. So the teacher gets everything together so that they help. Some of these schools have nurses, but some of still, even now we have difficulty because some schools don't accept these children. So till they are about 8 years of age, the parents go and give. After that, we transition the child and teach the child how to check blood sugars and take their insulins themselves.
Dr. Reshma is asking question, if the requirement of plant is below 10 units, you want to split into 2 times.
No, I continue only with once because I give it only at night and I cover by regular insulin early in the evening.
Thank you very much, madam. It was a fantastic lecture and very much useful for all the residents. Thank you very much, madam.
Thank you very much. Yeah, I'll just stop sharing 1 minute. Thank you so much for the opportunity and I wish all the students all the best.
Thank you very much. And here we are 4 students of Dr. Raghupati sir, Aila madam, Riyad sir, me, and now Lynette. So 4 generations together along with Raghupati sir in same lecture. Thank you very much. So over to Dr. Riyad sir. So I request Riyad sir to start just a 30 seconds about the MISTI application and also the Mithai program. Just 30 seconds. It can be asked in OSCE also. Sir, please.
Okay. Thank you, Amarnath, and the team is spearheaded by Shaila Madam and Ganesh for giving this excellent opportunity. And I'm so happy to be with my Guru Raghupati sir. And after the lecture of Dr. Anurag and Dr. Ahila, I think it is very easy to answer all these OSCE questions because everything which I'm going to show in these slides are already discussed. And regarding this Mithai program is actually a comprehensive diabetic care program implemented by the government of Kerala through the Social Security Mission, where all children with type 1 diabetes below the age of 18 are provided with insulins and also the other consumables. That includes insulin pens, glucose strips, ketone strips, and lancets. And also every 3 months, we provide them an opportunity to do a continuous glucose monitoring. And those children who are having brittle diabetes, who are really indicated, we can provide insulin pumps also. I think sooner or later this will come in other states also. In Karnataka, I am aware that Raghupati sir and Dr. Vani is trying to make it into practice with the government. Thank you. So
Thank you very much, sir. Just 1 second. I request all the participants to be active in this OSCE session. You are supposed to answer in your chat box. We'll be giving 30 seconds time after each question so that everyone can answer and everyone will get the equal chance. Yes.
Okay, I think the slides are visible now.
Visible,
okay.
Sir. Okay. Audible also.
Yeah. Okay. So I shall start with this video station because we know for DNB OSCE there could be some video stations also. So these are the questions. Identify the condition, name the type of breathing. You can describe the breathing pattern and 4 causes for the same and name 4 investigations to clinch the diagnosis. I think Dr. Amarnath will be keeping a watch on the chat box.
Yes, sir. Most of them they answered Kussmaul breathing, diabetic ketoacidosis, but nobody described about what is Kussmaul breathing. You can do that. 4 causes no one has written till now.
So once you are telling time is up, I will.
Shallow breathing. Yeah, we are giving 30 seconds, sir. I'm saying. Okay. Nobody described. Yeah, rapid shallow breathing.
Yes. So we know that this is an acidotic breathing because it is very important to identify acidotic breathing because when a small baby is brought with diabetes, we know that diabetes can happen in very young babies also. Sometimes even it can happen before the age of 6 months when we call it neonatal diabetes. So very easily the child can be misunderstood as a case of bronchiolitis or bronchopneumonia. and the treatment, that is the fluid management as well as insulin, may get delayed. So we have to see the pattern of the breathing. If it is a respiratory distress, if respiratory distress is associated with tachypnea, then it is more of a parenchymal issue, or sometimes even for bronchial asthma it can happen. But when it is a silent tachypnea, that is, it is a deep sighing type of respiration without any increased work of breathing, that is, without any lower chest indrawing, then it is acidotic breathing. So all of us should be able to identify or distinguish acidotic breathing from the respiratory distress in a case of pneumonia. And as we know, this acidosis or acidotic breathing can also occur in other conditions like renal failure, salicylate poisoning, lactic acidosis, and so on and so forth. And the investigation, we will definitely do a blood gas. We should also look for other causes by doing lactate and creatinine, and also ketones. Actually, the first investigation or the bedside test which we can do is just doing a urine ketone, because whenever a child comes to us with an emergency, most of the time we do catheterize and you take a fresh sample of urine and do a urine ketone. If you are having the luxury of having a blood ketone, it will be better than a urine ketone. So the next,
just 1 second, sir.
Yes, please.
One point of addition. The ASCII they can ask about the neonatal diabetes below 6 months of age. Whenever it is diagnosed, please do genetic testing.
Right.
That's okay. Yeah. Thank you.
Okay. So coming to the station 2, I don't know how many of you have seen this, because we have a habit of sending urine ketones to the lab, which we should stop after this class. Urine ketone strips should be available in the bedside, in our ICU or in the emergency, and it should be done then and there, because there is a question, the third question, how much time you will read. That is the most important thing. If you are sending it to the lab, you won't get a proper report. So you can see those questions and try to answer in the chat box.
Someone has said 10 seconds, 30 seconds, urine strips 30 seconds, 1 second, 20 seconds, and 40 seconds. Causes of positive test, no one has written. What is the cause?
Yes.
What is the principle? Beta hydroxybutyrate, urine ketone test kit. Beta hydroxybutyrate in blood.
Yes.
Value
So,
3 millimoles. Yeah, everyone
you can
answered.
just look at the legend given here also, because when it is more than 1.5 millimoles per liter.
But according to ISPAD, it is more than 3 millimoles. Yeah.
Yes. Like any value of more than 1.5 millimoles per liter, actually you should be suspicious, because this child can go in for a decay at any time. So answers for the question. These are actually urine ketone strips, and the reaction is based on the sodium nitroprusside test. And you have to read 40 seconds after the dip. That is very, very important. You can just dip the strip into the urine and take it out. Just it is a 1 second dip, and after that you wait for 40 seconds and look at the color. So you can just remember it's a deep brown color. That means ketones are large, and most of the time child will be going for a ketosis. And the hypoglycemia, I don't know, the question was about decay definition, and also hyperketotic hypoglycemia also can occur.
What are the causes of positive ketone strip test?
Yes. So it is hyperketotic hypoglycemia in conditions like GSD, then hypoglycemia in cases of hyperpituitarism, some IEMs, then gluconeogenesis disorders, as well as decay. And in blood ketone estimation, we measure beta hydroxybutyrate, which is a more dynamic test, because in the urine we usually measure more of acetoacetate, and it will stay for a long time. So it is the urine ketone strips are useful for the initial diagnosis. For the initial diagnosis, that is enough. But to look for the improvement, whether the ketone is coming down, urine ketone strips doesn't help at all, because it will remain positive for a very long time. But if you can measure the blood ketone levels, then it will also give you an idea whether the ketosis is improving or not. And as Amarnath has rightly pointed out, the cutoff for ketones is actually for DK it is 3 millimoles per liter.
Thank you very much, sir. Just for summarization, we request all the advanced ICU center, both NICU and PICU, should start using the blood ketone meter, which is very cheap. Each ketone strip cost around 125 rupees only, and blood ketone meter can replace the ABG also. And nobody answered the second answer. All of you note sodium nitroprusside reaction. That is a cause for urine strip test. Urine ketone strip should be used in primary health center remote setting, because it will take 12 to 48 hours to recover from the urine, even though from blood it disappears. Can anyone tell what urine ketones will show? What ketones are seen with the urine strip? What it measures? Blood, you said beta hydroxybutyrate. Very good. Acetone, mainly acetone and acetoacetate. Thank you very much, sir. Please go ahead.
Okay. And there is an instrument from HemaQ which can measure both the hemoglobin as well as blood ketone levels. Actually, the company people will give the meter free to the ICU if any hospital which is having an ICU, and we can start doing it in emergency cases.
Thank you.
Then this is a case scenario where a 7-year-old girl presents to the ER with severe pain, abdomen, respiratory distress, and which is there for 1 or 2 days, and her mother reports she has grown thin, that is weight is she's losing weight even though the child is eating quite well and drinking a lot of water. There has not been any cough or respiratory symptoms otherwise. So she also tells that the child had started bedwetting again. So everything is actually a telltale evidence of you know what it is. So now the child is lethargic, has sunken eyes, and has a deep, fast breathing pattern. Weight is 20 kg, and her abdomen is soft and chest is clear. But she's having a tachypnea, and the GRPS reading is 520. I'm very sure all the pediatric residents here should have seen such a child, and there won't be any miss in making the diagnosis.
They are writing 200 ml NS. Blood gas, most important. Blood gas.
So we know it is DK. And as the child is having this borderline BP, it will be good that you give a bolus. A bolus is not needed in all cases of DK. That also we should remember. How to identify severe dehydration, and some dehydration has already been described by both Dr. Anurag as well as Dr. Ahila. And the most important thing is when you are rehydrating the child, it should be slow. So even though there are new evidences which are coming, the rate of dehydration or the fluid we use doesn't make much difference in the outcome. It is always better to correct the acidosis slowly rather than fast. And with the fluid should be added with 20 milligrams per liter of potassium if the potassium is normal, and we will have to increase the potassium, the amount of potassium when we get a value of the potassium, because at the time of starting therapy we may not know how much potassium to add. So to start with, we can add either 20 or even 40 will be fine. But if you find that there is hypokalemia, you can increase it to 60 or if there is hyper, we can decrease it to 20. That will be the best way to do. And blood gas, we know we have to do so that we can assess the severity of acidosis, because according to the blood gas, by looking at the pH and bicarb, we divide DK into mild, moderate, and severe. When the pH is less than 7.1, it is severe. Between 7.1 and 2, it is moderate, and more than 7.2, take it mild. Why it is important is because we can manage at least some cases of mild decay in the ward, so that we can avoid an ICU admission. And bicarb also, the range is less than 5, 5 to 10, and 10 to 50. And always, as all the speakers were telling, we should be in the lookout for cerebral edema, which is the most lethal complication of decay. Most of the children who die during the management of decay die because of cerebral edema only. So always be concerned about increased amount of fluid, as well as rapid correction of hyperglycemia. Thank you.
Yeah, can anyone message what ABG parameter you want to look for the cerebral edema? As Anurag sir was mentioning. Anyone? Can start. Yeah, very good. CO2, PCO2, very good. PCO2 less than 10. Yes, go ahead, sir. Thanks.
Yes. And if somebody suspects cerebral edema, what imaging you will do before starting treatment?
Yes,
Anyone has written anything?
CT scan they're saying.
So the one important message is never shift the patient for a CT scan. If you are clinically suspecting cerebral edema, the first thing you have to do is you reduce the fluid by 1/3. And if the child is having no hypotension or low BP, you have to start mannitol then and there, because there is no need of shifting the child for CT scan at that time, because that will just deteriorate the child. Okay. So the next next station is name 2 common types of insulin regimen that are used in individuals with type 1 diabetes, and name any 2 insulin used in these regimens. And what is the chart the insulin dose plan for a 20 kg child with type 1 diabetes according to both regimens, and what is the commonest side effect of insulin?
Basal bolus and split mix, they have answered.
Okay.
Nobody answering the name of the insulin. Regular insulin, split mix. Name of the insulin, no one is writing.
Okay. So
yeah.
there are 2 methods. This was already explained by Ahila madam. You can see that this is called a split mix regimen. Split mix means here you are actually making the mix. I have written in small letters fixed mix. This fixed mix is the one which is otherwise called the pre-mix, where you have no liberty in changing the proportion of the insulins, the short-acting and the long-acting insulins. Like you get insulins like 50-50, 30-70, 80-20, something like that. So all these are not suited for managing children with type 1 diabetes, because they eat different meals at different times, and it is not suitable for managing type 1 diabetes in children. So in split mix, what we do is we decide according to the child's weight, eating pattern, the sugar values or the glucose logbooks which the child is maintaining, and we decide how much short-acting insulin or long-acting insulin to be used. The only thing is we mix both the insulins in one syringe, that is the short-acting and intermediate or long-acting insulin, and we give it 2 times a day. 2 times a day means in the morning before the breakfast, and also in the evening before the dinner. And we assume that the long-acting component which is given along with the morning dose of split mix will cover the lunch time also, or the lunch hyperglycemia also. And remember that this is an imperfect method of managing type 1 diabetes, but in resource limited settings, or if we cannot afford, or we cannot convince the parents enough for a basal bolus, this is used sometimes. But my humble request is all of us should tell the parents the children with type 1 diabetes needs more number of pricks, and at least 3 times insulin, 3 doses of insulin is necessary for their proper survival. And this is what is called this multiple daily injections or basal bolus regimen, where you can actually you actually give 3 doses of insulin with all the major meals, that is before breakfast, before lunch, and before dinner, along with 1 or 2 doses of basal insulin. So here it is written, this is aspart or lispro or glulisin as the bolus insulins before each meal, along with glargine as the basal insulin. We can actually do the same by using your regular insulin and NPH also, if the parents cannot afford. Here what we do is, we like in split mix, we give a combination of regular insulin and NPH insulin in the before the breakfast, a dose of regular insulin before the lunch, and also again a mix of regular insulin and NPH insulin before the dinner. So the child gets 3 doses of insulin, and these 2 doses of NPH will act as the basal component. So the basal bolus regimen doesn't mean you have to use the costly fashionable insulin all the time. It only means each meal is covered by a particular dose of insulin. So we can even do that by using a regular insulin and NPH combination. And for children who are at school, I will tell you there will be a practical problem, because we know that there should be a time lag between the insulin and meal when we are using a regular insulin. So in most of our children, what we do is they will use a regular insulin with NPH insulin in the morning as well as for the dinner, because both these doses are taken at home. They can have ample time for waiting after the insulin, like 20 to 30 minutes. But for the lunch at the school recess, as the time is very less, we actually advise them to take a short-acting analog where the child can eat just after the insulin. So another method, even the pump is intensified multiple daily with a continuous infusion of insulin. So that is another way. And always remember, insulin is given ahead of food. These short-acting insulin should be given ahead of insulin. And we now have some insulins which are ultra short-acting, like Feaspandol, that is fast-acting aspart, where the insulin can be given along with food. This is important. Why this short-acting analogs as well as ultra short-acting analogs are important is because in very small children and toddlers and all, they will be very fussy. So if you are giving a regular insulin dose, and after that, if the child just refuses to take the meal, the child will go for hypoglycemia. So in such children, it is always better to use a ultra short-acting or a short-acting analog at least, because this can be given in between the meals or just after the meals, so that you get a better control and you can avoid hypoglycemia. And all of us should by heart this chart which is given in Nelson, and we should be knowing something about these types of insulin, which are the rapid-acting analogs. There are 3 rapid-acting analogs in use: aspart, glulisin, and lispro, of which aspart and lispro are the ones which we use most commonly. And as pediatricians, we should be familiar with at least a few brands with these medicines. And we have regular insulin, just short-acting. And we also have this intermediate acting insulin, which is the NPH insulin. The other ones, the semi-lente and the things like that, are not available in the market. So we actually have rapid acting analogs, namely aspart, glulisin, and lispro. We have regular insulin, which is a short-acting insulin. We have NPH insulin, which is a intermediate-acting insulin. And we have basal long-acting analogs, namely glargine, detima, and also degludec. And regarding hypoglycemia, it is very important to teach the parents to identify the symptoms before discharge at the time of diagnosis itself. Because once the child develops a hypoglycemia, severe hypoglycemia with seizure, the parent won't be confident enough to optimize the insulin treatment after that. They will always remember the seizure which the child had developed after giving insulin. So such parents will always keep their children in a hyperglycemic range. So hypoglycemia should be prevented. So you have to teach them about how to adjust the doses and also tell them the symptoms. The symptoms can vary from tremor. It can there can be some amount of difficulty in speaking. The child may become irritable. The child may be behaving in an awkward manner. The child will have palpitation, child can have sweating. Sometimes the child can have unconsciousness as well as seizures. And if possible, in the event of hypoglycemia, do a GRBS. That is why this glucometer should be in the school bag. And we should tell the bus driver as well as the school teacher as well as one or two friends of the close friends of the child that child is having diabetes and child is taking insulin. The best thing will be having a ID card with a tag. So what to do with instructions about what to do if the child develops a hypoglycemia. So whenever the GRBS is less than 70, we call it hypoglycemia in a diabetic kid. We know that the cutoffs are different in other children. And it should be treated with 15 grams of sugar mixed in water, or we can use 15-gram glucose tablets. And actually, we should not advise the child to take chocolates or something like that, because that will take some time before the glucose level becomes normal. So it can cause neuroglycopenia and severe symptoms can occur. And always check the sugars after 20 to 30 minutes and make sure that the blood sugar has normalized. And also the immediate treatment of hypoglycemia by giving simple sugar should be followed by a snack. Then only the sugar level can be maintained later. Okay. Amarnath, do you want to add anything to this?
No, sir, nothing. Excellent.
Okay. Then I think all of you can answer this, how to match.
So if they ask what is the injection should be given for hypoglycemia, you can type.
Yes,
What injection you want?
Which is there any injection which the child can keep along with the glucometer?
Yeah, someone answered glucagon.
Yes, glucagon. So glucagon injections can be taken in severe cases of hypoglycemia, especially in children who are getting severe hypoglycemias and those who are having hyperglycemia unawareness as well as toddlers.
Good.
Okay. So are they matching this?
Yeah, all of you match. Degludec very long acting. Someone answered 1B. Lorgine long acting. Isopen intermediate acting.
Okay, all these were discussed before.
Yeah.
Also. Yes.
Yeah.
So these are the answers. Degludec is very long acting. Human actrapid is a short acting soluble insulin. Glargine is a long acting insulin. Human insulator isophane or NPH insulin is an intermediate acting insulin. And aspart, glulisin as well as lispro are rapid acting insulin. We also have an ultra rapid acting insulin called Fiasp, that is fast acting aspart.
Can anyone answer ultra long acting insulins? There are two now, newer insulins. This question was asked in theory. Yes, anyone who knows they can answer? So one is Degludec, second one is Toujeo. Glargine U300 is called Toujeo, and Degludec is called Tresiba. It can act up to 42 hours, 36 to 42 hours. Detimir also long acting. Go ahead, sir. Thank you.
So coming to the next station, hemoglobin A1C, what does this testing indicate? We know that we periodically ask children to do hemoglobin A1C who are on treatment for type 1 diabetes. And if we are, there is a first question, what does this testing indicate? Second question is, what is the cutoff to suspect diabetes? This is in a naive patient. If you are just doing a hemoglobin A1C, can you just diagnose diabetes as such, like we are doing a...
Someone has written 5.7, someone written 6. The question number 1, another question is missing. How much duration it tells the glycemic control? The question number 1, some part is missing. That also you can answer. Yeah, someone has written 6.5 cutoff. Last 3 months, very good. Desirable HbA1c in 8-year-old child. No one answered.
And any condition where hemoglobin A1C values may not be very reliable in monitoring.
Yeah, very important. Some hematological condition. Yes, hemolytic anemia.
With organomegaly, no? Organomegaly was discussed before.
Yeah.
Right. So, hemoglobin A1C signifies sugar control over last 3 months. And hemoglobin A1C of more than 6.5 is diabetes, provided the patient or the child is having classical symptoms of diabetes, namely the polyuria, weight loss, polydipsia and all. And if you're doing an hemoglobin A1C and you're getting a value of more than 6.5. And the target in 8-year-old, the new ISPAD guidelines tells us it is less than 7%. The American Diabetic Federation puts it as 7.5%. But if you refer the Nelson textbook, it is given as 6.5 to 8 because they have given different cutoffs for different ages. 5 to 11 years, they have given 6.5 to 8. So whatever you say, you can also always give the reference also.
Yeah, one extra question, sir. In case of thalassemia, what you want to measure? Not HbA1c, something else.
What else you can measure?
Yeah, you can message. Say, ask the question. Even in neonates also we do sometimes. Someone wrote C-peptide. Similar to hemoglobin A1C, what are the other? Fructosamine, very good.
Okay, okay, good.
Good.
So this is a child on follow-up after diagnosis and after managing the initial days. So these are the GRBS records of a child with type 1 diabetes who is taking insulin as follows. NBH at 12 units at 7 a.m., 9 units at 8 p.m., 4 units before breakfast, 5 units before lunch, and 4 units before dinner. I want all of you to name this regimen also. What is this regimen called? That is 2 doses of basal with 2 doses of intermediate insulin with 4 doses of 3 doses of short-acting insulin. And when you look at the values, we can see that some values are not acceptable. There are hypoglycemias, persistent hypoglycemias, CMS in all the 3 days. So what dose modification do you wish to make for this child?
Someone has written homogeneity effect. Split mix regime. Most of them written split mix regime.
So as I told you, whenever you see that someone is using regular and NPH insulin, don't think it is always split mix regime. This is again basal bolus because all the 3 meals, that is breakfast, lunch and dinner, all the 3 major meals are covered by an insulin. And there are 2 NPH insulin which are given for the basal action. So this is again basal bolus regimen, not split mix. Split mix means only 2 doses in a day.
Someone has written reduce the NPH dosage of night.
So we'll go to the answer. The correct answer is to decrease the night NPH so that this Somagi phenomenon is corrected. So what is Dawn phenomenon and what is Somagi phenomenon? Dawn phenomenon means the nighttime insulin is inadequate. or there is a heavy carbohydrate rich dinner, so that the 3 a.m. values, if we check, will be increased, and it will remain high when we check the 8 a.m. fasting sugars. And can anyone say why there is a increase in sugars at 3 a.m. or 4 a.m. like that? Early morning increase in sugars are due to?
Dr. Ahila discussed already. Someone written growth hormone, counter-regulatory hormone.
Yes, yes, very good, very good. Because of the rise in the counter-regulatory hormones during that time. So if you are identifying it is a dawn phenomenon, how can we identify the dawn phenomenon? By just looking at the 3 a.m. value. If the 3 a.m. values are high, as well as the morning values are high, you call it dawn phenomenon. And the remedy is to increase the nighttime NBH or nighttime basal insulin so that the hyperglycemia is corrected, or you decrease the night carbohydrate intake. So Maggie phenomenon means the nighttime insulin was excess or food was inadequate. Hence, the patient went in for hypoglycemia in the early morning, and the counter-regulatory hormones after that hypoglycemia has pushed the morning sugars to high. So here the remedy is actually to decrease the nighttime insulin or increase the carb intake at night. So it is very important to look at the 3 a.m. values at least once or twice in a week, so that we know we can identify between dawn and somagi, because the management is entirely different in each of these cases. So that is the importance of that particular question.
Sir, one extra question from my side.
Please.
Can anyone write in insulin syringe how many units per ml insulin is available, and in pen insulin how much units per ml? So someone has written 40 IU per ml syringe. Okay. In pen? Yeah, pen 100, correct. So syringe both are available, 40 IU per ml and 100. 40 is red color, 100 is black color syringe. Okay. Pen only single, that is 100 IU per ml. Go ahead, sir. Thank you.
So the importance is, when you are using a 40 unit per ml of insulin, the pen should be 40 unit per ml. And when you are using an insulin which is 100 unit per ml, the pen should be matching to that. So please check that. Otherwise, we will end up in trouble, because child can develop severe hypoglycemia because of the wrong doses. And regarding targets, there is a question: what is the pre-meal, post-meal, and pre-bed targets? Different societies give different targets actually, but most of us take the ISPAD as the standard. And for the pre-meal, it is 70 to 130 milligram per deciliter. For post-meal, it is 90 to 180. And for pre-bed, it is 80 to 140. But I have just made a footnote also, even in United States, only 22 to 23% of children below the age of 12 years and 17% of children between 13 to 17 years of age with type 1 diabetes cared by endocrinologists met the prior target of less than 7.5. So even though the targets are kept very stringent, in the practical world, it is very difficult to attain this. So for that, we need to have a holistic approach to the family. Because insulin is not the wonder drug, we need all the 4 pillars, namely the insulin, the diet management, as well as the exercise, as well as proper charting. We have new tools for charting, like the continuous glucose monitoring, where we also look into the time in range concept and also carbohydrate counting. All those things will help. And the next station is regarding counseling. A child with type 1 diabetes gets vomiting, diarrhea, fever, and tummy pains. What will you counsel the family regarding home management, regarding monitoring diet, insulin dose, when to seek? Because you should all remember, the child who had been diagnosed with diabetes on treatment will land up with DKA in your hospital only because of 2 reasons. One is either the child has become sick due to some other illness, or the child had stopped insulin, or child had missed the doses of insulin at least for 1 day or more than 1 or 2 days. So if you teach them properly how to manage a sick day, that itself will bring down the repeat admissions with DK. So that is the importance.
Yeah, Dr. Swati or Dr. Marin Joseph, anyone can answer this. Counseling session, sick day guideline.
If someone can just unmute and talk, that will also be good, because there will be a lot to write in the chat box. No?
Yeah. Dr. Swati or Dr. Marin Joseph, anyone can. Or even Lynette can. So most of them have written parental education.
Okay, so you have to write down and give a copy of sick day management. It should be a written plan. It should not be like just some advice. So actually we can, the most important thing is we should tell them on all sick days, you have to check for ketones, either the blood ketones or urine ketones, whatever is available with them. And also the blood sugars, like in any monitoring day, because we know that there are some monitoring days and some non-monitoring days for all children who are on treatment with diabetes, so on treatment with insulin. So all sick days are monitoring days. We may have to do multiple monitoring, like before food and after food and like that. And always tell the mother, because the parents will think that during the illness or during a fever or fever, vomiting, something, the child is not taking enough food. So we can either skip the insulin dose or we can reduce the dose. But that doesn't happen. What happens is, because of the illness, there is a lot of counter regulatory hormones coming out, and which will push your sugars high. So the child will be having mostly hyperglycemia rather than hypoglycemia. So no skipping of insulin during those days. You have to carefully monitor the blood glucose level, and according to the blood glucose level, as well as the presence of urine ketones, if you have a blood ketones, we may have to give some supplementary doses of insulin. And this chart tells us how to guide on the supplementary doses of insulin during the monitor. And when to come to the hospital, that is also important. When they are managing and they are seeing that the ketones are large and the child is having some symptoms of diabetic ketoacidosis, like abdominal pain, severe vomiting, the child is not able to take his food, all those things, all those tells us that the child should be taken to the hospital. And when we teach them the home management of a sick day, we should also make sure that the mother or the parent know when to take the child to the hospital also. So next is, this is about a 10-year-old boy who has come to you for his vaccination. And you have identified that the child is having, the weight is more, and the lifestyle is a little fussy, all those things, and the child is having acanthosis. So one important message is, when a child comes for immunization or some other mild illness, you are also supposed to look at the weight and height of the child, because growth monitoring is a very important responsibility of a pediatrician. And you have to chart it on a growth chart, and you have to identify which child needs intervention regarding his or her growth also. It is not just treating the illness. You have to look at the growth, and whether the child is growing adequately or whether the child is gaining weight more than what is needed. All those things you have to find out, and then you have to manage that also. So what all you will look in the history, investigation, management, and an account of BMI Sendails also. Anybody has written anything? Amarnath?
Everybody has written insulin resistance, insulin resistance, insulin resistance.
Okay. Okay. So in such a child, you have to ask for any child who is coming to you with overweight or obesity, you have to ask for the birth history, whether the child was an SGA, because we know that when an SGA child becomes overweight and obese, they are more prone for getting adult onset lifestyle diseases and the complications. So you have to look for family history of obesity. Somebody in the family is obese, that means there is more chance the child will develop other comorbidities sooner. And also look for some intellectual disability, visual problems, development delay, because all those are points regarding towards a syndromic cause of obesity. And also drug history, especially steroids and anti-epileptics, and sometimes some antidepressants. And also take a proper diet history and daily activities. You should actually ask the mother to take a recall history of the diet as well as an activity report when the child is coming for the next visit, and measure properly the weight, height, as well as the BMI on the chart. And management here, if it is an exogenous obesity, the more than the pharmacological management, here it is the dietary advice and daily exercise. And the dietary advice we should actually discuss with the family. Just writing and giving a diet plan or a list of foods is not enough. We have to sit down with the family and get the help of a dietitian and plan a what you call a weight reducing diet in case of this child. And then we have to monitor it intensively, as well as daily exercise should be started out. And here the basic mechanism of acanthosis is actually insulin resistance, and there is some amount of cellular growth which is intact, and overgrowth of cells we have in acanthosis nigricans. And regarding the BMI, it is no, in adults we actually have only 2 cutoffs. But for children, we need to use a growth chart. We need to use a BMI chart, because we cannot take a absolute cutoff for a child. The cutoff will depend upon what is the age of the child. So you can use this IAP 2015 growth chart, all our growth charts where you have this height and weight centiles. On the other side of the chart, we have this BMI centiles also. Here you can see that after the 50th centile, you cannot see any 75th or 90th or 95th centile or anything. There are just 2 lines. One is an orange line which tells us, which is at 23 adult equivalent. That means above that particular line, the child is overweight. And another red line where it is written 27 adult equivalent, that is above this red, the child is obese. So we know the Asians have these problems associated with obesity at an earlier BMI. That is why if you look at the books for everyone else other than the Asians, the cutoffs are 25 and 30, but for us it is 23 and 27. So you have to plot the BMI each time when the child is coming. And if you are seeing that the plotting is coming above this orange line or red line, we have to diagnose overweight and obesity respectively and start acting on it. So this is the last station. This adolescent obese girl came with neck hyperpigmentation. I think it is a very easy question. Everyone will identify what does it signifies and what are the components of metabolic syndrome, and is there any drug which we can use in such condition.
So many were answering diabetes mellitus, hypertension, obesity, acanthosis nigricans, obesity, hypertension, hypercholesterolemia. Most of them are answering.
Okay. So this is just about the staging of acanthosis nigricans. This is for the knowledge of the PGs. You actually stage it's like stage 1, 2, 3, and 4. The 1 means it is present only on close visual inspection, and stage 2 means it is limited to the base of the skull. It is seen only over the back. And the moderate means is extending to the lateral margins of the neck, and the severe means you can see acanthosis even from the front of the neck. So these are just for your information. There is a staging for acanthosis nigricans. And this is acanthosis nigricans, which signifies insulin resistance and a metabolic syndrome. And how do you diagnose metabolic syndrome in children? There are different cutoffs which are given for triglycerides, fasting glucose, blood pressure, weight circumference, and all these when coming together. That is, if there is a high waist circumference along with two other criteria to diagnose metabolic syndrome. And Vaman Kadalkar sir and team has already published waist circumference cutoffs for Indian children. And regarding the use of drug, never ever say that there is a wonder drug for overweight, obesity, and insulin resistance. The actual drug is always lifestyle management. You have to do dietary modifications as well as proper exercise. And for children who are doing that, if you are seeing telltale evidences of insulin resistance, we can try metformin. Metformin can just act as a adjuvant rather than a drug. So that is how you have to look at it. So with that, I'm stopping.
Thank you very much, sir. Dr. Yas, sir. 2 extra questions from my side.
Please.
Anyone can answer. Previously, we have discussed about this case, child with diabetes with hypothyroidism, alopecia, and also the mucocutaneous candidiasis. What is your diagnosis? Anyone can answer? Mucocutaneous candidiasis. Hyperpigmentation of the lips.
Answer has come actually.
Yeah, very good. One more question. An obese girl coming to you with the diabetes, type 2 diabetes, you have done the ultrasound abdomen. What are the 2 findings you want to see? Obese adolescent girl with type 2 diabetes. One is PCOS. Second one, fatty liver. Excellent. So you are all very intelligent professors. We are very happy, very actively participating. Now we'll go to the last few minutes. We first of all like to thank the Novo Nordisk for this giving the chance to sponsoring this session. We'll go to the classification of the insulins and time in range will be fast. So one second. You're able to see. We are grateful to Professor Raghupati sir. He is my teacher and mentor, one of the oldest pediatric endocrinologists of India, and we can call father of pediatric endocrinology. When I was a student, we learnt a lot of things, sir. So thank you very much. Sir is presently senior consultant pediatric endocrinologist, professor, and chairman changing diabetes in children. 22 centers in India, and his major achievement was the Best Clinician Award by the European Society of Pediatric Endocrinology, 2018. We are very proud of you, sir. So now coming to the positioning of TIR in diabetes management and role of newer insulins. So we are thankful to the Novo team so for sponsoring this program, and luckily they have given me the chance to introduce Fiasp and Tresiba first time in children in India, and also in insulin pump. I was the first person to start Fiasp when in trial stage. Thank you very much. So concept of the time in range. Previously HbA1c was most important, but at present the most important is in time in range. In 24 hours, how much time child is having the normal range of sugars? That is to take from 70 to 180. So how much hypoglycemia, mild hypoglycemia and severe hypoglycemia, 50 to 70 mild and less than 50. So this is a very, very important concept they are asking you in the question. So last year they've asked about the continuous glucose monitoring, HbA1c, newer insulin or insulin analogs. Except regular insulin, all other insulin comes under the insulin analogs, including NPH, degludec, glargine, the aspartate, and glulysin. So it refers to time spent in an individual, the target glucose range, that is 70 to 180, but occasionally 70 to 140. The percentage of time spent in below range or above range indicates the hypo or hyperglycemia. So TIR may be used as an appropriate endpoint in clinical research and measure of glycemic control in patients with diabetes. Emerging evidence suggests that TIR is inversely correlated to risk of developing microvascular and macrovascular complications in patients with diabetes. It is just like this. Previously, we were using the pager. Now pager is outdated. Now, then Nokia for mobile has come. Now Nokia is outdated. We want only Android or iPhone. Like that, HbA1c will be there, but the most advanced will be the time in range. Everyone will be talking time in range. How much time you are spending in normal range of sugars. That is the most important parameter to measure the long-term complications. What are the international consensus? We'll discuss about only type 1 diabetes here, that is 70 to 180. Little older means adolescents, more than 50% within 12 hours, and younger children 70%. So coming to the hyperglycemia should be less than 5%. So little adolescents up to 10%, and more than 180 to 250 up to 25%. Coming to the hypoglycemia, it should be less than 74%, and less than 54, it should be less than 1%. And just coming back to Fiasp, we did not tell you the beautiful molecule. The advantage with Fiasp is, especially the children who are going to the school, they can take the shot and take the insulin within 20 minutes. So just 2 minutes prior to the food or 20 minutes after the food, especially adolescent girls and teenage boys, they don't want to take in front of the other colleagues. So they can have food first, and within 20 minutes they can have this faster acting, ultra short acting insulin. So, and very less incidence of hypoglycemia with Fiasp. This we have covered. So correlation between HbA1c and time in range. So 100% correlation with 4.3% decline. So it is better to do TIR. So now all patients of type 1 diabetes ideally require, they have to keep the continuous glucose monitoring and take the range of sugars, whether it is normal or not. 1 or 2 minutes we'll touch about the even continuous glucose monitoring also here. So significant association of the time in range with the media intimal media thickness. So that is the atherosclerosis complications. Association between TIR and the maximum the cardiac adverse events. So it is very less when you use the time in range. So 10-year cumulative incidence of developing diabetes-related complications after improving TIR. You see the complications in type 1 diabetes, the end-stage renal disease, vision loss, amputation, myocardial. So better the TIR, lesser is the complication. Here 3.29, it's 2.25. Here 3.96, it is 3.57. So we have to increase the time in range. Ideally, it should be 80%, but it's very difficult. In my patients, we are able to achieve up to 50 to 60% in almost 70 to 80% of patients who are using continuous glucose monitoring. So, do newer insulin fare better? Just see. The half-life, if you see, degludec is only 25.4 hours, the maximum duration. Glargine only 12.1%. Flat time action profile in type 1 diabetes. See here. Lower day-to-day variability. So almost 4 times lower if you take the degludec. Similarly, day-to-day variability in glargine 300 versus degludec 2 times less. So degludec is better than even glargine 300 or Toujeo. The other name for glargine 300 is Toujeo. So consistently proven hypoglycemia benefit across the study. You're able to see always degludec is doing better than U300. Again, consistently proven hypoglycemia benefit. Conclude trial showing it is better with the degludec. As a flat profile and lower risk of hypoglycemia, what about the time in range? So superiority of the insulin degludec, estimated treatment difference is significant, that is 1.43% or 20 minutes per day in favor of degludec. So glucose variability is very, very less. So now HbA1c is replacing by the glucose variability and time in range and time above or below range. So time below range also you see it is very less with the degludec compared to glargine. So more patients achieved the significant difference in TIR. So this is the CGM monitoring. You're able to see the hypoglycemia and hyperglycemia. This is a normal range 70 to 150 they have kept here. So CGM profile with improved TIR. So complete TIR, that is time in range between degludec and glargine. It is better with the degludec, that is 77.3. Significantly lower glucose variability has been seen with the degludec. So 2-year randomized control study shows the cardiovascular is decreased 24 hours with degludec. Summary, time in range provides a closer view of person's glycemic status and aids in better glycemic control. Increase in time in range. So ideally we should keep 80%. So decrease the microvascular and macrovascular complications. International guidelines have now been updated, include consensus on CGM data. So compared to glargine 100, degludec has improved TIR and lower nocturnal hypoglycemia. Thank you. Now we'll see any other doubts, please. I request you to ask the doubts, please. Once again, we thank you, the Sonali, the sponsor from the Novo Nordisk, for giving this chance. So can anyone answer the microvascular and macrovascular complications? You can message here, we will see. Yes. Most of them you are all answering. So So just a few slides will go about the continuous glucose monitoring. This question has been asked to you. Are you able to hear me? Yeah. Here you are able to see the reader and the sensor. So this is the reader, this is the sensor. This is 5 rupee coin like thing. It will be attached to the arm and will be recording the blood sugar level every 5 minutes. Okay. So this is a sensor you are able to see here. So sensor kit package, this you have to applicator, you have to applicate, and you have to do the application. So this is the reader from which you can USB port, you can take all the readings. Okay. So this is how you should record the CGM, continuous glucose monitoring. So here you are able to see the normal range is 70 to 180. This is given in millimoles. So even you can see the normal range. When it comes below it, it's shown as red color. So check glucose, review history, it will show like this. So high, low, your low you will be able to see as red color. High, you will be see as higher than like this. So this is how your continuous glucose monitoring question has been asked in the theory. You can write about that. So time in range already we have told 70 to 180, 80% value should be normal. 5% hypoglycemia allowed, less than 70, and 1% below 54 of sugars. So here in advanced glucometer, you will be able to see the rising quickly, the trend. So rising glucose is rising, changing slowly, falling, glucose falling quickly. You will get the alarm. So these are the advantages. So glucose history will get every 15 minutes, you can take the reading. So 32 readings within 8 hours. So very user friendly, you can use along with the even the insulin pump also. Thank you very much. Now I request Raghupati sir to speak few words and conclude the session.
Good evening, everybody.
Sir, your face is not visible, sir.
You have to stop sharing.
Okay, sir.
Good evening, everybody. I'm sorry I joined late. While you're talking on DKA, I had 2 patients, new patients, arriving with the DKA. And as usual, the parents were very upset with the news that the child has got diabetes and requires insulin for life and all that. And I thought I was successful in pacifying somebody and getting them admitted. Another patient also arrived at the same time. And so I was held up, but I'm very happy that the session went off very well. And there were nearly 100 participants. And I saw the active...
4 of your students are here. 4 of your students, Dr. Ahila, Dr. Riyaz sir, me and Binet.
I heard that. I heard that also. And
so happy to see you, sir.
Thank you. Thank you very much. I am happy that there was active participation from the audience, and quite a number of them came up with the right answers. I'm sure if you conducted this OSCE in the same style as Dr. Ahila did a quiz program some time ago, I'm sure many of you would have done gloriously. And what really pleases me is the interest shown by all the postgraduates in pediatric endocrinology. And this was the very idea with which I started this teaching program in the beginning itself. And we were doing it in different states, one by one. And I'm so glad Dr. Anurag also has started the same program. And he's much more active than I am, and much more younger also than I am. And he's continuing this. And I would like all the postgraduates who attended today to spread this word that we are having exam-oriented training program. This is what I would like you to know. And I wish there will be greater participation in the future. And I must really thank all the speakers, Dr. Anurag, Dr. Ahila, and Dr. Riaz, and Dr. Amarnath for their active participation, and Amarnath for being the ringmaster. You know,
Sir is very inspirational. He's just like a tiger. So we are learning. So
you are the
he's so
ringmaster.
loving. See, sir never scolds me, I remember, and he's very much loving. He used to tell stories for 1 to 2 hours each patient. We remember everything, sir.
So you are controlling the tigers. That's why I said
No, sir.
ringmaster. Anyway, I'm happy that program went out well, and we expect greater participation in future. Thank you all.
Thank you, sir.
Thank you so much, sir. Great to see you.
Thank you very much. Thank you very much, Ankit, for very good coordination. We thank the ISPE president and especially the Novo Nordisk for giving this sponsorship. And we thank you all, especially all the students who have taken active participation. We are grateful to all the patients, teachers, and all the people. Thank you very much.
Bye, sir.
Okay.
Bye.
Bye, Shaila. Bye,
Bye.
Riaz. Bye, Aman.
Thank you,
Bye-bye.
madam. Thank you.